Yeah. Okay. So I'm just going to start. Dr. Jayanta, we are okay with time? Yeah. So thank you very much. Everybody can see that.
Yes.
Thank you. Um, Welcome everyone to this grand round symposium, I would say, on tendon transfers in foot and ankle. This was actually an idea by Eric Blumen, who is from Harvard. He and myself, we were chatting about it and came up with this topic. And I think uh, very interesting topic in foot and ankle, very rarely discussed in most of the big meetings. And I think this is the first time we almost have a 2.5 hour of discussion on this sole topic, I think, in India. This has been carried out under the aegis of Indian Foot and Ankle Society from the guidance of Dr. Rajiv Vora, who is the current president, and Dr. Ajoy from Bangalore, who is the secretary as well. Really, thank you very much for allowing us to be under the guidance of Indian Foot and Ankle Society.
Our
Also, I
pleasure,
would,
Manish.
I would like to thank Farmed, who has been kindly given this platform on Zoom webinar to conduct this webinar, and also a donation towards the Indian Foot and Ankle Society as well. We have main faculties, Dr. Eric Blumen, who is associate orthopedic surgeon and a professor from Harvard. I'm not going to go through the whole details. I'm sure everybody knows about him. You have Dr. Vinod Panchbavi, a very close, near and dear one, who's been regularly seen in all the Indian Foot and Ankle Society meetings, a regular traveler to India, I would say, who has contributed a lot of his time to the Indian Foot and Ankle Society education, I would say. Then you have Andrea Belkovich. Is that correct? Andrea, did I get it right?
You did exceptionally well done. Thank you.
Thank you, Andrea. Thank you. She's a remarkable foot and ankle surgeon from UBC, British Columbia. I'm part of the Canadian Foot and Ankle Society as well. And then last but not the least, Dr. David Richardson, who's an associate professor from Campbell University, from the Campbell Clinic, I beg your pardon, Campbell Clinic. Thank you very much for joining us in this grand symposium, I would say. We have the Indian faculties, Dr. Rajiv Vora, Dr. Ajoy, and Dr. Mittal, who kindly agreed to be the case presenters for this symposium. So without taking much of time, I'll hand over to Eric, who will be talking on basics and science of tendon transfer. Off to you, Eric.
Thank you. Thank you. I'm going to take the screen now if I can.
Yes, I've stopped it, so please go ahead.
Okay, thank you. So I have changed the title of my portion just slightly. Instead of basics and science of tendon transfers, I took the liberty of changing it to tendon engineering, and you'll see why in a moment. And again, I want to start off by saying I don't have any disclosures that are really related to this. My fellowship does receive money from Arthrex, and they make products directly related to this, but no bearing on the presentation. I want to start out by saying thank you. Thank you to everybody, especially the Indian Foot and Ankle Society and Professor Vora, Secretary Ajoy, and of course Pradeep. Pradeep, I love you with more facial hair. I found this picture and I couldn't resist. It's so I am very, very happy to be here, and I'm happy all of us are as friends are here together. But I am slightly saddened that we won't be in India later this year for IFAS Gone. So why are we talking about this? And Pradeep alluded to this earlier. And it's I think an undercovered subject, but of extreme importance. And I think I am a believer that tendon transfers, especially about the foot and ankle, are really the highest art. And if someone who I'm going to let you in on who this quote is from, but said, if you can conceive, plan, and conduct a successful tendon transfers, you can do any procedure in orthopedics. And at the time, it left me scratching my head when I first heard this, but more and more, I'm a believer in this. And this was sort of passed down to me from my mentor, Mark Meyerson, who is a master at this. And I've learned many things from him, and this being one of the most important. So getting back to the title, I wanted to say that this is a clarification and a suggestion. A tendon transfer technically is one of many procedures that it's meant to modify the function and improve the condition of the patient, but it's commonly, but really inaccurately used to refer generically to a family of these procedures. And I would say that really what we want to do is have a better nomenclature, and that better nomenclature really should be tendon engineering. There are many different types of tendon surgery, but tendon engineering is the deliberate modification of the function of a motor unit by manipulating its functional characteristics, and that's really what we're talking about here today. So brief outline, we're going to talk about the basics. They include nomenclatures, goals, prerequisites, principles, and types, and then also go on to the science about it and different aspects of that. So let's start with the basics. So the nomenclature, a tendon transfer is really a relocation of a tendon insertion to a new site. This is to be compared to a tendon translocation where you're rerouting the tendon without disruption of the origin or the insertion. A muscle or tendon transplantation really may not be done so frequently by orthopedic surgeons, but our plastic surgery colleagues help us out a lot with this, and this is really typified by an entire motor unit being detached and implanted into a new location, typically with something like a free flap. And then tendon suspension is the rerouting of a tendon to create support for a structure. So some examples of this, some that is probably familiar to most of us, is an FDL to PT transfer. That is a true transfer. The rectus femoris transplant, as you can see here, taking from the thigh and then brought down to the leg, that is a tendon transplant. A Jones Teno suspension, where the EHL is detached and then brought back and looped through the first metatarsal head, is a Teno suspension. And then a Young's procedure, where we have a translocation of the route, really changing the routing of the tendon through a slot in the navicular, is a translocation. And interestingly, it is also classified as a Teno suspension, so it satisfies both of those goals. So prerequisites for successful engineering. You need an analysis of the needs and goals of the patient. And what I've tried to illustrate here with these two patients, you have both of these patients have cerebral palsy. This one on the right, this patient is very functional and is able to do some very demanding athletic activity here, typified by weightlifting, whereas this patient was suffering from the same condition but is nowhere near as functional, and those goals for these two patients are probably markedly different. We need a knowledge of the patient's appreciation for surgery, and you need to have adequate soft tissue bed for coverage, and this is maybe something that we take for granted, but we really need to think about when we're talking about tendon engineering. We need to make sure that there are mobile interposed joints. A tendon transfer done across a fusion or an ankylosed joint will not be of much help to our patient. And the donor motor unit has to have adequate strength, sufficient excursion, and expendability. These principles here are very important to keep in mind. We need to have strength. We need to know the amplitude. We need to pay attention very much to the direction of line of pull and also to the attachment. And specifically, we need to know where the offset of that tendon engineering procedure is going to end up so that an appropriate amount of force can be generated. There are some special principles that I think we need to really concentrate on. And the first one is synergy. And within synergy, You need to pay attention to the phase. And we talk about this a lot, but many people, especially my trainees, are not able to define this. They have a general idea of it, but not an in-depth knowledge of it. And this is the normal period of the movement cycle during which the motor unit contracts. In phase refers to the contractile period that is same or very similar to that which is being augmented. And this is playing upon a physics principle of constructive interference. You are adding to the motor units that you already have. And the out of phase refers to when the contractile period is different to that which is being augmented, and this is very, very analogous to destructive interference. And as you might imagine, we want to play upon in-phase transfers as much as possible and downplay out-of-phase transfers as much as possible. This is not always possible, but we want to always aim to do in-phase transfers. The second special principle of synergy is integrity. The transfer should have a single function. We shouldn't be asking our tendon engineering procedures to do multiple things at once. We should aim to have them do a single thing. We want to make sure all the components of the transfer act to create a balanced and concerted motion. And I'm hoping that Dr. Richardson is going to talk about this and highlight this in his talk about bridle procedure. I'm not going to go into this too much because I know David is going to cover this, but you can see that there are multiple components that are acting to create a single goal, get us to a single goal. Multiple transfers should have matched excursion, and this is really typified by the quadriga effect. You can't have multiple tendon slips with different excursions because they will either underperform or not perform at all to the same level. Let's move on to the science now. Talk a little bit about tissue biology and tendon bone healing. This slide isn't meant to go in depth, but just to show you that over the past 60 plus years, there's been a robust history of research looking at what is going on from a basic science perspective in terms of tendon to bone healing. And this continues up until the present time. One set of studies that I want to highlight are that from Scott Rodeo from HSS, when he looked at what happens with tendon implantation in bone tunnels. He did some studies looking at with dogs and did some histology that I think is very instructive for us. There's a formation of tissue at the tendon bone interface at 2 weeks, and you can see that here, where you've got tendon on the upper corner here and bone in the lower right-hand corner here, in this broad, very well-defined interface that is seen at 2 weeks. Then as we move between 2 to 12 weeks, you see that the bone is ingrowing into the tendon, and things have been switched up here. Now the tendon is on the bottom and the bone is at the top, but you can see that those interfaces are much less robust and much less distinct as the bone is growing into the tendon. And finally, as you move out to 26 weeks, you get this maturation of that interface, and it's really hard to pick out a distinct interface here, and you have a really, really integrated interface here. When we translate those histologic findings into biomechanical findings, it really helps us understand pullout strength, and this is important for us as surgeons because we want to get these people moving quickly, but we don't want to get them moving too quickly where we will damage or minimize the work that we've already done or damage the work we've already done. You can see here that at about less than 8 weeks here, there's failure at the tendon bone interface, but then if we go out to 12 weeks, the pullout failure was within the mid-substance of the tendon or the clamp, so that interface has become very robust and the strong point of the transfer. Types of fixation, I commonly get questions about this. What is the best way to fix your tendon engineering procedure? It can be done through bone tunnels, staples, suture buttons, bone anchors, and interference screws, all of which have their place and all of which can be used successfully. This is a busy slide, and I don't want to take too much time going through all the details of it, but you can see that interference screws in a couple of these studies were found to be superior to bone anchors, and I think that is overall a good baseline, a good mantra to keep in mind when you are doing your tendon transfers. But as I said, all of these can be used successfully in different places, and there are certainly places where interference screws cannot be used because of the volume of bone you're dealing with and the location of bone tunnels and whatnot. Anchorage is also important. Many people feel that putting the tendon into cancellous bone is optimal, and for many indications that is true. That is not to say that cortical anchorage should be abandoned in all cases. This study in JBJS from 1995 showed that you can have very effective anchorage of a tendon to the cortex itself in terms of load to failure, energy to failure, stiffness, and the actual histology of that bone tendon interface. Tensioning is also a common question, and there's a lot of level 5 evidence floating around about this. People want to know, what tension should I set the transfer? And many people revert to a Blix curve, which we all learned in physiology in medical school, and thinking that there's an optimal tension that will give us the optimal strength of pull. And on a superficial level, this is true, certainly in the acute phase. But there's been some studies that have been done more recently out of Japan, which are very, very interesting, showing that both the muscle and the tendon adapt to the tension at which you set your tendon engineering procedure. So basically, this graph is showing that with an over-tightened, if you will, over-tightened tendon transfer, tendon engineering procedure, you will first get muscle elongation through the addition of sarcomeres, and then a subsequent lengthening of the tendon. And then that is eventually followed by a subtraction of the sarcomeres. So the body will set that optimal tension itself if you don't achieve that initially with your surgery. On a cellular and molecular level, there are a couple of molecular things to think about. BMP2, as we all know, is a growth factor. This, as you might imagine, strengthens the tendon to bone attachment. Osteoprotegrin is a soluble inhibitor of NF-kappa B, and this enhances attachment within the tunnel. And rank ligand, which is a stimulator for osteoclasts, can weaken that attachment, and that all makes a lot of intuitive sense to me, and I hope to you too. Non-steroidal anti-inflammatory drugs have been shown to lower tendon pullout strength in treated animals, and it seems to inhibit the formation of a stable interface between the bone and tendon. COX-2 inhibitors seem to have a greater inhibitory effect than non-specific inhibitors, and these general findings are supported by a number of different studies. Nicotine delays tendon to bone healing, which probably is not a surprise to anybody. Histologically, it creates a chronic inflammatory response and decreased cell proliferation. And in studies that were done, the mechanical properties of organisms in animals that were exposed to nicotine, those mechanical properties lagged behind those that were not exposed to nicotine. So in conclusion, nomenclature is something to think about and pay attention to, because these are a very diverse set of procedures, and I believe tendon engineering is a better term than just generic tendon transfers. It is an art. It is what I consider to be where art and science interface the most within foot and ankle surgery. You need to define your goals when dealing with your patients. You need to plan using those principles that have been set out. Healing time is important, and 12 weeks is a magic number in terms of these procedures. in terms of formation of good strength at the tendon bone interface. Fixation there are multiple good methods to use, and tendon to tendon and interference screws seem to have some superiority. The anchorage site can be done both in the medullary bone as well as at the cortex. And some overtensioning is definitely compensated by the adaptations that an organism is able to impart on our surgeries. Biologic factors influence bone tendon healing. And I just want to end by saying, once again, thank you to Pradeep and the Indian Foot and Ankle Society. And as I was doing this presentation, I reflected on a gift that Pradeep gave to me. This is Lord Shiva, which I didn't know about. I did not really know too much about Shiva until Pradeep gave me this. But when I was looking at this and reading about it, I think that there are some very pertinent components to this for our current situation. One of the many arms of Shiva is this open palm, which from my understanding is a symbol of protection. And also Shiva is standing on a demon and suppressing the evil. And I think hopefully Shiva can help us in this situation we're in with this pandemic and protect us and help us put down this affliction that we are globally seeing right now. Thanks again. I really appreciate the opportunity.
Thank you very much, Eric. Very succinct presentation. There's one question which had just come up from Muhammad Mekhamer. Overtensioning adapted, so if in doubt, no harm from overtensioning, Eric?
Yes. I heard the first part, but I didn't hear the actual question.
So what he's saying is overtensioning has a little bit of adaptability in your tendon transfer or tendon tissue engineering. So is there any harm in doing slight overtensioning? I think that's a question.
Yeah, and I think that's very well stated. I think a slight overtensioning is compensated for. I think at the ends of the spectrum, too little tension or too great of overtensioning will not be able to be overcome, and you'll end up with a tenodesis effect rather than a dynamic effect that you may be hopefully looking for with your tendon engineering procedures.
Sure. Yeah, sorry, go on.
So I have a question for Eric. Great, excellent presentation, Eric. A lot of basic knowledge, which we overlook at times, and it's really useful for our management of tendon transfers and so on and so forth. You mentioned a tight repair can be compensated by sacromial, alteration there. But what happens if you end up doing a lax repair? Does the muscle and tendon, contract over time? Is there any basic science addressing that?
Yeah, I mean, that really was not covered in that study. But I think, to my mind, I think we get a good idea about that empirically because we see it through many different conditions and many different outcomes. If you don't have adequate tension and there's an undertensioning, you'll get contracture. And we see this in paralytic phenomenon. We see this with people who are immobilized for too long or for improperly. And I think there's a eventual contracture formation and fibrosis. And so I think small amounts, again, I think are able to be overcome. Large relaxations probably will not be able to be overcome.
So there's one question, Manoj, for Blumen. Can I ask a question?
Yes, please, Rajiv, go ahead.
When we are doing the tendon to tendon suturing, once we have completed the suturing, many a times we find that we are in slightly under tension in those cases, particularly when you are doing tendon to tendon. Are there any finer adjustments which are recommended during tendon to tendon versus bone to tendon using interference screw or something like that.
And so are you finding that your tendon to tendon fixations are more prone to under tensioning than if it was anchored to bone?
Yes, that's
Yeah.
correct.
Yeah, I think it's very difficult, and I think you're right. I think especially when you do a tunnel going through the bone, it makes it easier to set the tension,
Yeah.
especially using techniques like interference screws. And I have found that too. I think it has to do with the ability of you or your assistant to hold the tension properly, and then also how we suture and some creep that engineering creep, biomechanical creep that comes into play, especially when you're dealing with tendon to tendon fixation.
I have a question. Eric, you described so many ways of anchoring the tendon. If you have to choose one, which one you choose? There's a
Well,
natural, yes.
Yes, that's a great
If you have
question.
to choose one,
I have never experienced, to my knowledge, I've never experienced failure when I suture the tendon to itself. So if I loop it through a bone tunnel or loop it around a bone, I've never experienced failure with that. And I don't think I can say that for any of the others. Certainly with suture anchors I have chosen bone tunnel and interference screw diameters improperly that have led to slippage. I've used staples that have failed, but I think if you can do a tendon suturing to itself, that is the best technique for me. And I think that's highly dependent on individual preference and your abilities. But for me, that's the gold standard.
I'm sorry, I'm just going to cut through. Eric, there are 3 or 4 questions which have been gone through. If you be kind enough to just go on your Q&A and answer
absolutely.
them. If you just type it, so we also know the answer, and then if you have time, we'll take it. Interesting questions from both Indian and international faculty. I'm really sorry, but I think for pressing of time.
Let's go. Let's move on.
Sure. May I, if you kindly, and thank you very much. I think the comparison between the Shiva and the knowledge which you put through, I mean, it's great, remarkable, Eric. Hats off.
Thank you.
And I had a great time with you, Eric.
Me too.
I remember that corridor which we took the photograph. There's another one with a feather. You remember that?
Yes.
I'm sure you do. Okay, may I invite our very own Vinod Panchmavi, who will be talking on harvesting of tendons. Off to you, Vinod.
Okay, so you need to
Eric, stop. If you stop sharing that screen, please.
Yes, I'm challenged right now. Got it. New share.
No, on the top.
Stop
if you go
share.
stop
Thank
share.
you. Sorry.
Yes.
Yep.
Thank you. Thank you.
Okay, I think I am sharing my screen now. Okay, there you are.
Yes.
And I think you can see my screen.
Yes, we can see.
I'm going to expand it. So thank you, Eric, and thank you, Pradeep, for putting this together. I know it is a really interesting topic, and I want to go over some of the things which, I have found difficult and what I did to improvise. So here's a picture of a foot. This end is a toe. Can you see the arrows there? I'm pointing arrow.
Yes, we can see it, Vinod.
And this is the heel. And this exposure, this is during my fellowship days, back Dr. Trevino, my mentor and fellowship director at that time. So this is the posterior tibial tendon there. You can see it's very, we still have it there, but what we were trying to do was fetch that flexor digitorum longus from the depths of that midfoot. So to go deep, you have to extend the incision quite a bit. And the reason you want to get the maximum length is to be able to loop this tendon through a bone tunnel and suture it to itself, just like Eric mentioned. So this was the problem. You see, at that time, the medial approach provided poor visibility. There's a lot of vessels there. If you open these vessels, there's always bleeding. You can't see it. And my fellowship, Dr. Trevino, bless his heart, he's a great guy, but he used to get so frustrated because we are not retracting enough for him. We're not changing the lights enough or whatever. So there was there, and obviously the risk of neurovascular injury. So basically what we're trying to do is going from the medial aspect of the foot all the way across to harvest this tendon. And you want to harvest this tendon towards the end, to maximize the length just before it branches into its slips. But you're going across those neurovascular bundles, so it is a scary thing to do and a big incision. And often you're left with a long scar. Obviously, if you're using a bone tunnel, an interference screw, you may not require that much length. But if you are hoping to use a bone tunnel and then bring it out and then use the extra length for whatever other purpose, then you want to maximize on the length available by the tendon. So this was the hypothesis I thought of at that time. I thought there must be a better way of doing with this. Thought, okay, could we just go ahead and then use a kind of a probe and push this probe in that sheath. So we had about 83 cadavers, and we pushed this probe, and then we wanted to feel where exactly it ends up in the midfoot. And we wondered whether if we make an incision right about at the tip of that the probe, can we harvest that? So that was the hypothesis for our study, cadaver study. So we were able to, locate that probe and the tendon in the close vicinity. So we thought, okay, we know that we can cut that tendon and then bring it out from the proximal wound. And that's the point of the navicular. So you have plenty of length from here on up to the end of the tendon. And we wanted to know whether while doing this, are we doing any damage to the adjacent structures? So we raised a flap, and we wanted to see where we went through this, this is plantar fascia aponeurosis. And this is the neurovascular bundle. So folks, if you go from the medial aspect, you are going across this neurovascular bundle to get to that FDL just before it branches out into its slip. And, we got another publication out of it, which we have shared. What this publication tells us is you can consistently find, it's like a GPS location, you see, so we can pinpoint in 3 dimensions, or at least 2 dimensions at least, so one dimension is, in the vertical plane, so you have the base of the second toe and the back of the foot. The FDL is exactly the halfway at the midpoint of this dimension there. And from the medial border to the lateral border, it's 1/3 to 2/3. If you make an incision there, you'll be directly over that tendon just before it divides, and you can minimize the length of the incision because you don't want to make a longer incision than necessary in the plantar aspect of the foot. So this is what we found in our cadaver dissection, and I have started using this. First patient I used, I was really nervous, but we were able to do that. You can see that this slip is going to the FHL, and the length is pretty, long enough that you can pass through this bone tunnel, and like Eric was mentioning, you can actually suture it back to itself. And perhaps, if you reef these limbs together, you could actually do a teno suspension for that talonavicular joint, perhaps use it as a alternative or reinforce a spring ligament. Okay, so there are definitely advantages of harvesting this tendon close to where it divides, and also use a smaller incision instead of extending the incision all the way in order to maximize on the length. So, this is a work in progress. So I thought, okay, this incision, when I tried to publish this, there was a lot of criticism saying that this is going to be a painful scar and so on and so forth. In my clinical experience, we did not find that, and we published that in a different publication. So, and we're kind of building the arch up, a flat foot has an arch, and then hopefully this scar doesn't touch the floor when the person walks. So, but the question is, can we avoid this incision altogether? I think we can. We do have lots of tendons snares, and this is one which we are working on currently. So, what about FDL? FHL. We often use FHL for Achilles tendon reconstruction. And in 2006, this was standard technique. Dr. Wapner, Keith Wapner, a great friend of mine. He published this technique in Foot and Ankle Internationally. This is the medial aspect of the foot. You can see again, it requires a long incision. And sometimes people would like to do a tenodesis, for the remnant of the FHL to the FDL to maintain some kind of power in the great toe. But, studies have shown that that probably is not absolutely necessary. And even if you do not do that, people are functioning okay. And obviously you can have a short harvest and use, some kind of absorbable suture and don't have to go in deeper in the midfoot. But again, I was kind of, this is again a picture taken from my fellowship days. And this is the medial aspect of the foot, which we did manage to get that FHL. Again, it leaves a long incision. And the other thing is, when you are repairing the Achilles tendon, the patient is prone, and going to the medial border of the foot becomes a little more difficult. As it is, it's difficult when the patient is supine. But imagine the patient is prone, you're looking upside down and working through a deep, dark crevice to get from the medial border of the foot deep into the midfoot area to get that FHL. So again, but you can certainly do this. That's a long scar from, I thought, okay, we've done this FDL. Can we do this for the FHL? Again, we do the same thing. I wanted a longer length. I will tell you why, because you can use that length for other purposes. So this is what, if you just secure in the figure 9A, you can see that the FHL, is cut short in the hind foot, and using a bone interference screw in the tunnel, you just use that. But then you don't have anything to do to connect the triceps. And I've seen folks, just ignore the triceps altogether. But if you have an extra length, not only you can pass that tendon through the bone tunnel, but also use the remnant to reattach or bridge the gap between the triceps muscle and the Achilles tendon stump. So a short flexor hallucis longus harvest, you probably would waste a motor if you don't do anything to it. A long FHL harvest will provide you the tendon to recruit the triceps, and what I tend to call is a double bundle technique. Maybe there's a better name. So I'm going to give an example here. This is a patient. You can see, which side is the tendon gone. At that time, we used to do the both sides. And you can see somebody has already been there, and we have to remove all this unhealthy tissue, and then that was gap I was left with. And you can see I'm passing my probe and feeling the tip, and you can see at the end, you can also expose the tendon at the base of the great toe and also in the midfoot. And, you can cut it away from the base of the great toe and then bring it out in the midfoot area. And that is the connection to the FDL. That's the Henry's knot. And you can bring it out and, certainly get a good repair done. And it proves to be, almost, I added like a belt and a suspension. I added a aponeurosis there too. And you can see this, probably the video, you can see the post-op time she's able to do that, and then she's able to go up on her toes all by herself in the follow-up. This is kind of a short video of the critical portion of the harvest. So basically we are here, it is scary because, you can be near the nerve and you have to make sure that you are not going to hook up the nerve. You need to This is what I'm trying to do, is making sure you're using a blunt probe to go over the tendon. And, with a knife, you can use a longitudinal incision to expose that tendon. The tendon has got a different look to it. You can see the shininess, the shiny, tiny, you see that shiny tendon appearing. If you move the toe, you can see the tendon is moving. So now it's a right angle hemostat, which is, I'm trying to hook that tendon. I know that's a tendon, and the structure looks like a tendon, shiny fibers, not yellowish. So that's a tendon there. You can confirm that is a tendon by moving the toe. Now, I'm going to tell you something else which I've started doing recently is, that the skin freeze incision was right at the base. Now I do it more distally. I get a little bit, about extra centimeter longer length. So we detach that tendon there. Now it comes out easily in the midfoot. Now you need to pull on that tendon. Then while you're pulling on this tendon, you can actually see and move it on one side these are retractors in place. You can see that connection right there. You see that's a connection going to the lesser toes. We know that's a connection there because if you watch the lesser toes, they start moving when you pull this. It's the bottom of the screen. It's going to come in view in a second. And, you can also, what you can do, your own feet. If you try to bend your big toe, the lesser toes, if they bend, that means we have the connection. See, that's the connection. So when I'm pulling on this connection, you can see that the second and third toe are moving. So that's the connection we need to remove in order to get that tendon up from the hind foot. So the knife is going to come in and cut that thing over there. It's a very short video, very ending soon. I just try to make sure that we expose the tendon well. And there you are. You see, cut the tendon there. Now the tendon is free. We can actually tug on that tendon to see if there is any motion in the second and third toe. If there is none, that means we have free and clear. We have removed that master knot of Henry. And now we come back to the wound at the back of the leg. You can see the FHL sheath has been opened up. And I'm trying to hook that tendon. That tendon is very muscular, way down, and you can see easily that it's been exposed. I'm asking my resident to have the pleasure of pulling it out, and there you go. Very shortly it will come out, and the whole length is there for you to route it through the heel. You can make a percutaneous incision there on both sides, and then bring it out, and then you have plenty of length to hook the tendon back up again. So let me go on to, there's another example here. You can see the calcification in the tendon. The whole tendon is unhealthy all the way up to down there. So no use pretending to save it. So you remove that tendon again. Same thing. I'm trying to show you the nerve is very close by. You do not hook that one. You need to make sure that you have the tendons in vicinity and take it out and then bring it out. Like I said, I just want to show you. This was what I used to do, but I do the incision for the distal, get a little bit more length. And you have plenty of length, folks. You can you can check that your triceps is working. You see the triceps, if you contract the tricep, it's working. So, many people give up on triceps. I don't. You can see this is again post-op follow-up. I'm going to show these. But one thing I've noticed is the calf muscles never come back. This I think is about 6 months to a year, and they can certainly go up on their toes, but the calf muscle takes forever if at all they come back. So you see, he's able to stand on one leg, and that's the kind of repair I do. That's the old way of open harvest. I have switched completely to the minimally invasive. There are some of the publications we have shared. Thank you so much for the opportunity again. Appreciate IFAS and the office bearers, and there's so many webinars. I love
very good.
participating in some of those. And again, thank you, Eric and Pradeep for putting this through and the opportunity.
Thank you very much, Vinod.
Thank you.
Very excellent presentation and good videos. I'm sure, I think people will start harvesting the way which you have done. And I think you have been very passionate about this techniques which you have shown. Um, any questions from panelists? I'm just going to see any Q&As is happening. Anything you want to add? Yes, Dr. Mittal.
How many cables were you able to make out from this, you see, long graft to fill up that gap of the tendo Achilles?
I can go one time and then come back. So two.
Two. Okay.
Yeah.
Okay.
Good. Good technique. Wonderful.
And the key thing I think in that is, especially if you have a long FHL, you do not need any implant. Means you're just going back through the bone, and then you can weave through it. And as Eric said, a tendon to tendon repair is the best repair you can get. Is that correct, Vinod?
Yes, yes. Obviously, like you said, I don't like to put any foreign bodies. I don't use bone tunnel, interference screws, absorbable, non-absorbable. I don't use the. I think, and I did not see in Eric's presentation if there is any comparison between bone tunnels versus interference screws, but there might be. I don't know, but I think bone tunnel, inherently provides a lot of strength to this. Perhaps earlier rehabilitation and so on and so forth. So, why waste money on implants if you can avoid it?
And especially around the Achilles tendon area where you want to keep as minimum area, as minimum foreign material as you can.
I have seen, there was one question by Nikesh Shah, mentioning whether absorbable or non-absorbable. You see, I have gone both ways. With the absorbable, one patient came back with infection, and we thought we got it all out, but they came back again after a few months, the infection. So it's very difficult when it breaks down. There are remnants which we cannot find, and you can't see. But with a non-absorbable metal ankle suture, you can actually take it out, and then there is infection. We can get rid of that. But that's what one drawback which I have noticed with absorbable sutures in that location.
Okay. We know there's some questions on the chat, so I'll just take a few. Eric, do you want to add anything onto that? What Vinod said about bone tunnels to suture anchors to anything else?
No, I think that Vinod has been an absolute pioneer in this. I don't know. I consider myself an early adopter of this and teach all my residents and fellows his harvesting technique, and it's been for adult flat foot surgery and tendon, doing a tendon transfer has been revolutionary for me. My blood loss and avoiding that medial leash of vessels on the plantar medial aspect of the medial column is virtually eliminated. And it's one of the, it's so valuable for my practice. Thank you, Vinod. I really appreciate you doing this.
Okay. Vinod, there's a question. I have seen Vinod sir operating. He's excellent in Galveston. His views on tendon transfers in diabetic foot and any indications?
Oh, diabetic feet. If they are neuropathic diabetic, we see, I think I would go more for fusion rather than tendon transfers, to be honest.
Sure. Okay. One more question from Praneeth Revuri. I think he's one of our IFAS members. Wanted to know if FHL harvest is better than FDL harvest for tip post transfer. Can you hear that, Vinod?
Sorry, what is it?
There is a question from Praneeth. Wanted to know if FHL harvest is better than FDL for tip post transfer.
Yes. This is a good question, actually. I think Roger Mann, I don't know if I'm remembering correctly, but I think he tried one or two times FHL. But you see, FDL is very next to the posterior tibial tendon, lends itself very well. For FHL, you have to cross the neurovascular bundle. And there are some reports, actually, the FDL rises up to the occasion. And I know there is the strength difference and the diameter difference. if you consider the diameter, FHL is larger and perhaps more stronger than the FDL. That's one way you may want to do that, but I think moving the tendon across the neurovascular bundle, number one, and so I think that's the main concern I have, and FDL being very next to the posterior tibial tendon, that becomes a favorite tendon, if you will.
May I comment?
Because I think it hypertrophies and rises to the occasion, and we are adding often a medial calcaneal slide. You see, so you're bringing in the Achilles tendon also to work and help the posterior tibial tendon function.
I think what the participant is getting at is, and I think there were 2 or 3 talks in the World Congress which Mark Myerson did it, and I think one was from Korea and another one from somewhere else, where they have started doing a primary FHL transfer. And what they do is, instead of attaching into the navicular, they really go up to the base of the first metatarsal, thereby stabilizing the whole medial column. And I think that's why people have started to do using FHL. Any take on that? Both Vinod, Eric, and David, Andrea.
Well, I have not used I have not used for a posterior tib insufficiency, if that's what we're talking about. I have not used the FDL nor for an Achilles repair. I've tended to use the FHL in large part, like Vinod said. It's just so easy to harvest when you're posterior to obtain the FHL. And Andrea probably has a comment on this, but before I go, I did want to, number one, that was a great talk, Vinod. I don't think that there's a big concern about having pain on the bottom of the foot with these plantar incisions. I know there's a JBJS article looking at 100 consecutive plantar incisions that really did not show much issues with a plantar incision. So I think that's certainly a theoretical concern, and we've probably all had someone that ended up with some pain with these incisions, but I don't think it happens as often as we might be concerned about.
Okay.
For me, I routinely take FDL when I'm augmenting tibialis posterior or doing my arch. I do a lot of joint preservation, so it's really important to get the tendon set up properly. I try to over-tension a tiny bit, but not a ton. In terms of the Achilles, I always do a posterior approach and use the FHL, which I think is very important. Again, over-tensioning a little bit and ensuring that I have the good insertion of the tendon, which I think does create a better balance, specifically the proper lever arm. So I think that's important. But I love this idea of going down to the foot, and I think I'll probably be using it more now as a result, because the dissection is immense, and then that leash of vessels is certainly a concern. I think, to go through that and risk potentially the medial.
Sorry, go on, Andrea. Go on.
Yeah.
Hello.
Oh, so that's good. So for me, that's all I would add. Yeah.
Yeah, but do you think? What do you think about this? My question was using the FHL and in place of FDL and inserting at the base of the first metatarsal to stabilize the whole medial column.
Well, there's some thinking about that. So it depends on how much planus you have. So if you're looking at a highly collapsed Mary's angle or arch height, I think there certainly is a role. In fact, I've used it into the medial cuneiform. So I've not gone as distal as the first metatarsal, but I have done it in the medial cuneiform as an arch suspension. Mm-hmm. But now that you mention it, I think there is a rationale to go more distal. But I don't use it for an augmentation. To post in that setting. In that setting, I use it for people who I'm doing joint preservation that have severely collapsed Mary's angles. That I think that you're doing double level osteotomies on, and it would be really nice to have this almost that tenodesis effect on that arch. Good. So I think it's a valuable thought and something that needs to be studied more.
Sure. Anything to add, Vinod?
No, I think all excellent points there. And David has mentioned those plantar incisions, and not painful. I agree with him. But when I was trying to publish that, I got shot down saying that this is a plantar new where nobody has done it before, all that kind of stuff. So, but it turned out it was worked out okay. Thank you.
Yeah,
Thank
because they would always say that the inventor or the main person who's done would always have a bias. So I think it's a good thing somebody else has published it. Just gives more authenticity to your technique. You know.
Yeah, I will say I know of that article because my father published it.
Okay. Fine. Last question, I think, before we go. Is there any upper age? Is there any upper age limit for tendon transfer? You know.
Upper age limit. Again, I don't go by the age. Age is a number. Dr. Mittal, if he's coming to me for surgery, definitely offer it to him. But no, it's activity. If the person is really active, even at 90, 80, people are living longer and much more healthier life. Thank God. So physiology. I'll go for
Of course,
physiology.
of course.
I
Thank you.
think age is irrelevant personally. I think it's about the presentation of the foot, the imaging that it comes in as, the mobility, the flexibility of the foot. I mean, if it's a young person in their 20s completely non-flexible with terrible imaging, you would never consider it. Whereas someone in their 70s with a beautifully flexible foot wants to play tennis, wants to hike mountains, I would treat them as if they were 20.
Fantastic. Thank you so much. Excellent talk and great discussion. There are some few questions. If you just don't mind going on Q&A, and if you can answer them, please, I would be really grateful. And next, I would like to invite Andrea Vilkovic. She's from Canada. Thank you very much, Andrea, for coming over. I know it's quite early in the morning and you are out in the woods, but thanks for taking out the time. And she'll be talking on forefoot tendon transfers. I've already sent her papers to all the delegates. If you have not received it, please let me know. We'll be more than happy to send you. Off to you, Andrea.
Okay, perfect. Can you guys see my screen?
Yes.
Okay, great. I'm just going to start the presentation then. So I wanted to thank you guys for having me as part of this presentation. It was very valuable to meet you all. And I'm going to see if I can start this talk. So I'll be talking about forefoot tendon transfers, which I think is actually a valuable topic. And in general, disclosure-wise, I have no disclosures pertaining to this talk other than in addition to Eric. I also have fellowship support from Arthrex, and I do use some Arthrex devices in this talk. So on the outline side of things, we look at the pathologies of the forefoot as being one of the major issues. And we'll also look at tendon transfer options for flexible deformities, as well as outcomes. So, sorry. Strange, it's not progressing. Oh, there we go, sorry about that. So in terms of toe deformities, tendon transfers are powerful tools in the primary treatment of flexible forefoot deformities or as adjuncts to bony procedures. We know that there's many deformities amenable to tendon transfers, and these are hallux varus, clawed hallux, hammer toes, as well as the more complex angular lesser toe deformities. And these are really the bear of my existence. So in terms of the great toe, we have flexible hallux varus, and we know that this is often a complication of hallux valgus surgery. And in fact, the incident ranges from about 2 to 17%. We know that it can come from anything where you're over-resecting the medial eminence, doing over-plication, or doing fibular sesamoidectomy. And now with the advent of people using more lapidus, you get overclosure of the IMA. So interestingly enough, and I've seen this in my practice, is that hallux varus doesn't cause significant complaints. You notice it more when they're more than 15 degrees. And again, it's more of a cosmetic issue. Sometimes, however, they get MTP degeneration, which can be an issue, or rubbing of the toe distally. So this can be either classified as static or dynamic, and it can be uniplanar or multiplanar respectively. And basically what you're looking for is that the static hallux varus is flexible, passively correctable entity. And most of the deformity occurs at the first MTP joint in the frontal plane, as well as the deformity often results, as we mentioned, from excision of the medial eminence or overclosure of the IMA. And you can see here that as a result of this, you get a change of pull of the tendons, and this actually causes the opposite effect of hallux valgus, where now you get that reproducible hallux varus occurring. So clawed hallux is a deformity of the great toe. It's a flexion of the first IP joint and extension of the first MTP joint. This deformity is a result of imbalance between the extrinsic muscles of the first ray, which include the peroneus longus, EHL, and flexor hallucis longus. And this goes to what Eric Blumen was saying in regards to Mark Meyerson, where, you know, the art of foot and ankle really comes in soft tissue balancing and tendon transfers. And this is also seen in the art of deformity. This imbalance can be seen in pes cavaveris. You see this because the tib ant and the peroneus brevis are peroneus longus are no longer in balance. And it can also be due to weakness of the intrinsics and plantar fascial contractures. In terms of lesser toe deformities, these are caused by alterations in normal anatomy that create an imbalance between the intrinsic and extrinsic muscles. And I think this is the key. Often we'll say that it's improper shoe wear, but I think it's this balance that is very, very important. We also have it from trauma, genetics, inflammatory arthritis, and neuromuscular and metabolic diseases. And each of these act a little bit differently, and we think of treating them differently in terms of whether or not we do fusion or balancing. So typical deformities that occur in the forefoot are mallet toe, hammer toe, claw toe, curly toe, and crossover toe. These abnormalities are associated with the MTP, and then what we see in the MTP in the first ray is hallux valgus, or obviously varus, and especially in the lesser MTPs, specifically the second toe. It's important to note the anatomy, and I really won't be going into this, but you need to know what your extrinsic muscles are and your intrinsic muscles are, and it's nice to refer to this graph when you have time. So for mallet, characterized by DIP flexion deformity, they have a neutral PIP, and they have neutral MTP joint position. These people get pressure of the toe against the end of the shoe, and this can cause DIP flexion and tightness of the FDL. And in fact, sometimes I think they use this for proprioception, and that's why they're bending it. Mallet toe is also caused by rupture or laceration of the EDL of the DIP. And less common, the distal phalanx can deviate either medially or laterally, and you need to address that. In terms of the hammer toe, this is characterized by PIP joint flexion deformity. And typically they get extension of the DIP. In terms of the MTP joints, they're extended, or more commonly you see these people have it in neutral. It occurs in conjunction with other deformities. The entire array must be evaluated for MTP joint instability, and I think this is key. Also, you have to evaluate your radiograph specifically for an excessively long metatarsal that may need to be addressed, or MTP joint subluxation or dislocation that also will need to be addressed. Claw toe, very different, is characterized by PIP and DIP joint flexion deformity. And you always get this MTP joint hyperextension, which can be varied in terms of degree to severity, to the point where it's severely dislocated. Hammer toes can exhibit one of those properties, but not both concurrently. And claw toe is less common and typically more severe than hammer toe. The most important thing when you see this deformity is that claw toe deformity can be indicative of an underlying neurologic condition, such as Charcot-Marie tooth, or something spinal or intracerebral that you need to assess. And therefore, neurologic evaluation should be done before corrective surgery is performed. And this is the key. Now, when you look at claw toe, this is actually quite interesting. You know that you have weaker intrinsic forces that give way to stronger extrinsic forces that you can see by this diagram by Dr. Mann. MTP joint extension is caused by the action of a strong EDL tendon on the extensor sling. And when you have this, you get MTP joint extension, and the insertion of the intrinsic muscles gets changed or is rotated. It lies at an increased angle away from the normal direction of pull, and this needs to be addressed. When the MTP joint is extended, the weakened intrinsic muscles allow the tensioned FTB and FDL tendons to flex the PIP and DIP joints. So this is what you see, and I'm not going to go through this graph typically, but you obviously need to know about your mallet toe. The difference here is that really it's a DIP deformity with flexion. Hammer toe, here it's the PIP that's flexed, and sometimes the MTP can be involved. With claw toes, you always have MTP extension, and then you have flexion of the PIP and DIP. And that's just really important when you think about how you're correcting the deformity and balancing the forefoot. So lesser toes, I hate this deformity, and I have a difficulty with this. I've tried everything you can think of for this, and it's an evolution for me in my practice. So crossover toe deformity and isolated MTP joint angular deformity. This can result in significant pain due to pressure effects of adjacent toes from shoe wear. These deformities can result from intrinsic and extrinsic causes, such as trauma, inflammatory OA, congenital deformities, and constraining footwear. You can have an isolated MTP deformity, and often you see a valgus or varus angulation at the MTP joint. But it can also be associated with a great toe angular deformity, and you need to address this when addressing the lesser toes. A crossover second toe deformity is defined by the second toe crossing dorsally over the first, but in fact you can have the opposite where it deviates laterally, and that's even more difficult. So these can result from a cascade of trauma and synovitis, and it's followed by subluxation and dorsal or inferior medial dislocation of the proximal phalanx on the tarsal heads. Other findings are laxity of the collateral ligaments, which provide stability in the transverse plane, and they also resist subluxation of the proximal phalanx on the metatarsal head. Imbalance between these intrinsics and extrinsics can result in lesser toe deformities, and this also happens in the midfoot and hindfoot. However, the intrinsics in their normal anatomic relationship act as MTP flexors and PIP and DIP extensors. So once you change this relationship, you get an imbalance and you get deformity. In the case of the second crossover toe, laxity and subsequent rupture of the LCL and lateral capsule can occur, and a long second metatarsal is associated with attenuation of the first dorsal interosseous tendon and plantar plate. And it's interesting because now you look at the nuancing effects of these angular toe deformities, and to address them, you might have to address these nuancing effects. So now we look at treatments. So when we looked at this earlier, we talked about the flexible hallux varus, and the key is that it has to be flexible. And multiple treatments have been described. Originally, we had the split transfer of the EHL tendon, and this is nice for flexible varus. And the idea here is that you rebalance the EHL, and you take it from being superior, and you take it to being infralateral, and this hopefully helps you rebalance the toe and rebalance the sesamoid sling for you. Now, the question is, how do you do this, right? I used to do this earlier on in my practice and have moved a little bit to other techniques, and we'll move on to those in a bit. But this is done basically, you can see here that you've done a medial release, and you can do this through a MIS technique also, where you can actually release it distally and strip it proximally, and then transfer it. But this is just so you can see how it's done. Then of the capsule, and the EHL is split in line with its fibers. Now what you want to do is you take that distal piece that you have here, and you want to reroute that under the intermetatarsal ligaments. And so that this way the ligament acts as a pulley and allows the EHL to be transferred to the pull, hallux plantar and lateral to the axis of the first MTP joint. So dynamically it helps improve the situation. Then what you want to do here, and this is what I've published in the past, is a 4-0 drill bit is then inserted to make a tunnel from the dorsal medial, and this is important, to the plantar lateral. So what it does is it depresses it for you, and it lateralizes the toe for you. Finally, you then pass the tendon from lateral to medial in this tunnel, and it's secured with an interference screw or sutured to itself. And certainly you don't have to be wasting money on interference screws in my viewpoint. This can be nicely done by suturing it to itself. And that's why that bone tunnel is such a good thing to use, right? So then we look at the outcomes. What we found is that these patients do get some decreased first MTP motion, but this is the tenodesis effect or the suspensory effect that Eric discussed with our tendon engineering. Alignment is generally improved, however. They have some mild residual varus, but again, these patients don't complain about this, and their ground contact actually is improved. What we noticed from Furman et al. Is that actually these patients have an average varus of 14, but they actually don't notice it clinically. Now we come to newer techniques that are available out there, and there's an endobutton procedure that's available, and this is really trying to suspend and recreate that lateral LCL or the lateral capsule. There's no really great long-term results on this, but basically what you see here is you have a dorsal incision between the first and second MTP, and here you would actually make a nice vertical capsulotomy so that you can plicate the LCL, and medially you would release the abductor, right? And so you come in, you do your medial release, and now what you want to do is recreate that lateral collateral. So you drill from inframedial to supralateral in the proximal phalanx, and you want to be drilling down a little bit here to bring that toe down, similarly as we described with the EHL transfer. Now you would do your metatarsal drilling from supramedial to infralateral, ending where the origin of the collateral is, and then that's where you would place that drill hole. And then you would just pass your device. Usually often I start from the phalanx, go around, and then pass it to the metatarsal. And you want to make sure that you don't over-tension it, but you want nice tension on this device. So here's an example of that in one of my patients. So this is a lovely female that suffered from a severely long second metatarsal, which is a complex issue, but she was also pathologic from her planovalgus foot. So we had to correct her hind foot and her midfoot, and we brought her down, as you can see here. And I've overcorrected the IMA here a little bit too much personally. In addition to this, we also did an angular toe correction for her with a transfer, and we'll talk about this later, of the EDB under the intermetatarsal ligament of the second. And then you see that she does originally a little bit well. It's not an over resection of the medial eminence, but certainly I've overclosed the IMA. And you can see here that she starts to fall off a little bit. And so as a result of this, I said, well, you know, I don't really want this to continue further. And we ended up doing a suspensory that we talked about. And she actually has an exceptional result. And for some unknown reason, she asked me to do her left side, and that's been completed too. And she's actually quite happy. And you can see here that when we did this procedure, we wanted to ensure that our first ray was elongated a little bit, and that our second ray now was matching to the third as best as we could. It was no longer excessively long as it was. Now we look at the treatments of claw hallux, or the clawed hallux, which is flexible. The key thing here again is flexible. We know that there's a modified Jones procedure. And basically here, you can do this either open, or you can do it more minimally invasive as Liu et al. Described. Doesn't matter how you want to do it. The key thing is here, you want to first find the tendon, and then you want to prepare the IP joint for fusion. So the EHL tendon is identified and tagged, and then you want to make sure that you bring it up proximal. Now you want to fuse your IP joints with whatever you want to use. I use a cannulated screw, doesn't matter what device is used. And then you make a dorsal midline incision, or you can do it percutaneously, as you can see here. And you use a 4-0 drill bit to go across the metatarsal head-neck junction, okay? And then you pass the EHL from medial to lateral and suture it back to itself. And the key thing here is that you want to make sure that your ankle is neutral dorsiflexion and that the deformity is corrected. Again, I like to overtension by a little bit of 10 degrees because I do think that there's a little bit of a creep to the tendon itself. You don't need to use, anything fancy, just suture it back onto itself. Now we look at clawed hallux again. These are other techniques that are available. You have the flexor hallucis longus tendon transfer to the proximal phalanx. The nice thing about this is that it avoids fusion of the MTP. So this essentially preserves the function of the EHL and does not require fusion of the IP joints. It avoids lack of dorsiflexion and the stiff great toe of the modified Jones that has been described. The question really is reproducibility and function, right? So the technique here actually is a medial incision along the hallux overlying the proximal phalanx. We just make a little medial incision, it's quite nice. And then the FHL tendon is identified and the sheath is incised in line with its fibers. The FHL is released from its insertion on the distal phalanx, and you can do that minimally invasive if you want. And then the metaphyseal-diaphyseal junction is identified dorsally, and you just use a 4-0 drill bit. And then you pass the tendon from plantar to dorsal through the tunnel and wrap it on itself, or use an interference screw. I tend to use interference screw here, but honestly, you don't need to be doing that if it's an expensive technique otherwise, right? So now there's a minimally invasive approach that has been described, and this has actually been described by Yui. This is quite nice, where you actually would basically make a 1 centimeter incision, small one, on the plantar aspect of the proximal phalanx. You would identify the FHL and tag that FHL, and then you make a small incision on the dorsal aspect of the proximal phalanx, dissect down, okay? Use under fluoroscopic guidance. You don't need to be using huge incisions here. Use your 4-0 drill bit. Maybe don't make the drill bit as long as pictured in C, which I really don't like to see that much. And then you can pass the suture. So this is just a cheap method. This is using an angio cap. And then you can actually grasp that angio cap and bring it out back. So this is actually a cheap method described by Dewey, where you don't have to use fancy techniques. And here the FHL tendon is transferred from the plantar to dorsal and sutured to the extensor tendon when the deformity is corrected. So there you go, quite nicely. It comes out, it goes through that EHL, and you can suture it down. You get a nice effect to bring that clawed hallux down. And it gives you more of a better suspension of that proximal phalanx. And then you suture it back to itself here, okay? The nice thing when you look at the outcomes is both the Jones and the FHL transfers are equally effective in correcting deformities at the MTP and IP joints. And there's a benefit of avoiding IP fusion with the FHL transfer. In you do get some catching of the great toe, but patients are pleased. They don't have this clawed toe anymore, which is difficult to fit in shoes and difficult to negotiate. They do, however, once in a while get recurrence of the clawed toe deformity that's been reported, and it's apparently been attributed to the regeneration of the distal EHL stump. They can get stiffness of the great toe, but this is considered a downside of this procedure, and we know that. When it comes to FHL transfer to the proximal phalanx, alignment appears to be maintained on follow-up with good pain relief and satisfaction. They, however, can't return to that strenuous activity as, you know, they have an issue with push-off. FHL transfers, so this is done the MIS way. There were good results, and this was not a robust, long study, and I think it warrants further study personally, but I think it's a really nice way to do things, same as Vino talked about, doing things a little bit less invasive with less scars to the foot and ankle, which I do think has a benefit. Now we go to our flexible hammer toes, and we've talked about this as the Girdlestone Tailor, and this is the flexor to extensor transfer. The nice thing about this is that it allows the FDL to act as an intrinsic on the proximal phalanx. It allows, therefore, for its depression, and at the same time avoids its native deforming force on the distal phalanx. So basically, the technique is fairly simple, right? You basically make an incision. I like to make it over the middle phalanx. I personally like a vertical incision because then that avoids injury to the neurovascular structures. I use a mosquito, make my way down, identify the tendon, and then this is where it becomes really finicky personally. You split that tendon, and immediately I put sutures on the end. Then dorsally, I make an incision over the proximal phalanx. You don't have to make it this robust unless you're addressing the MTP joint. I dissect down very gently with my mosquito down the side of the bone, again, avoiding the neurovascular structures. I find these tendons and very gently bring these tendons up. And they're much more friable than you think. You have all these great intentions of doing a great case, and then you're playing with these tendons. They never look like this in the OR. They're much thinner, more wispy, right? So then you actually, what I do at this point is I pin the toe in the position I want. And then once I pin the toe in the position I want, that's when I tension the tendon on top. And I know that I have a reproducible good position of this. So now you can see this here. This is an example of one of my patients. She has a third hammer toe that was quite flexible for her. In addition, she had that depression of the metatarsal head, and her pain was actually at the metatarsal head in addition. We basically did a Girdlestone Tailor on her, pinned the joint, and then that's what she looks like at the end. She's nice and straight, and she's actually quite happy and asked me to do again her left side. So there's other ways of doing this so that you don't have to do it, you know, doing this huge dissections. You know, we have this transosseous flexor to extensor tendon transfer, and here is transosseous. So instead of splitting the FDL in a plantar fascia, in the plantar fashion, here you actually would harvest it and plant it. Here's the biggest issue for me is lesser toe angular deformities that are flexible. Okay, and then do you guys see it now?
We can hear you. We just see your picture.
How about that?
Yeah, fantastic.
Yeah, sorry guys, I knew this might be an issue. I apologize.
Don't worry.
Okay. Okay, so for lesser toe deformity, and you guys hear me, yeah?
Yes.
Okay.
Yes.
So here the issue is that the MCL and medial capsular contractures is associated with LCL and lateral capsular attenuation. And actually you can see this on the other side too. So it doesn't always have to be MCL being tight. Sometimes it's LCL. But the key thing is knowing which side is the deformity, right? So when you're treating this, you want to release the tight structure, in this case the MCL off the metatarsal head and phalanx, and you want to repair or augment the LCL. And then you can K-wire this. So the tendon transfer techniques for this can be used, but it's also used for to dynamically stabilize the coronal deformities. Okay. In addition, there's fixed components of PIP deformities. These can be done with bony work. And in terms of MTP extension deformities, you may need MTP decompression and potentially a while osteotomy. So these are the two techniques we'll discuss, and then hopefully we'll be done with the presentation. Here you want to do a dorsal incision over the proximal phalanx and distal metatarsal. You want to identify the EDB and follow it proximally. And then you want to release the MTP joint capsule and enter it transversely. Here you want to release the MCL, lengthen the EDL on both sides, and then 4 centimeters proximal to the joint, you want to secure the EDB, which you can actually see up here. And then you want to release the EDB, right? So then now, once you've done that, you actually can get the distal EDB tendon and pass it from distal, as you see here, to proximal under the transverse intermetatarsal ligament on the convex side of the MTP. So it doesn't have to be lateral, but it can be on the other side depending where the deformity is. And then the EDB is tensioned and secured to the proximal stump, right? And then you want to make sure that you K-wire the MTP joint in the position you need, and then you deal with the EDL. Your secondary procedure that you can do is called the modified extensor digitorum transfer, and Haddad has a nice talk about this here, where you would make a dorsal incision over the proximal phalanx. Again, EDL is Z lengthened and tagged. You would enter the MTP joint transversely and release the contracted ligament, whether it be MCL or LCL. Here in this picture, it's MCL. And then 4 centimeters proximal, you want to make sure that you secure the EDB with sutures and transect it through these sutures. And now you do an oblique tunnel. So there's your oblique tunnel there, where it's orientated distally in the proximal phalanx towards the convex side of the joint. And then the distal stump of the EDL is passed through the bone tunnel from medial to lateral, or from the concave side to the convex side of the deformity. And then the EDL is passed from distal to proximal under the transverse intermetatarsal ligament on the convex side of the joint. And then you would actually suture this. So you would make sure that you correct your coronal deformity, K-wire it, and then the proximal stump of the EDL is sutured to the distal stump. Final thing here is that if you actually want to look at reconstructing the damaged collateral ligament, there is a technique. So you can see here that we identified the EDL. We Z-lengthen the EDL here. And then the next step here is to find the EDB. And you want to release the EDB quite proximal up here, like this. So you actually release EDB quite proximal up here. Then you tag the EDB. And once you have EDB tagged, you now look at the MTP joints. You know that in this case, you're actually tight on the lateral side, on the medial side. And what you would do here is you would come in, identify this, and then you want to release the collateral off the metatarsal head, off the proximal phalanx, like you can see here. And now comes the fun part. You can take your megalomary and just release the head a little bit to get some more excursion and get your reduction. And now you will drill from medial to lateral. Take your K-wire across and then use your drill over that, which is nice. Same thing goes in the metatarsal head from medial to lateral, aiming to where the collateral originates. Over drill that, okay? And now pass your passing sutures. And now what you're going to do here is you're going to take EDB and root EDB through that bone tunnel to recreate your collateral ligaments or your LCL. And then that gets transferred in. You don't have to use the interference screw, but if you want, you can. And then that gets transferred through the metatarsal head. And you can again use another interference screw there, or you don't have to because it's a lot of money. And then you would secure your EDL at the end of that. So there's an example of a case similar to that where we did that transfer, and you can actually see here that you get the nice wild osteotomies in this deformity. And in this case, we actually transferred it on the contralateral side or on the outside, and you get a nice reproduction of that deformity after you're done. So when it comes to complications of this, the complications are inability to obtain anatomic correction of the deformity. You can get recurrence of the crossover toe deformity. And the outcomes actually, 77% were actually quite satisfied with this. And Haddad looked at the difference between EDL and flexor extensor transfers, and he found there was really no statistical significance, but the authors thought that EDB transfers versus FDL tendon transfer resulted in better mobility and range of motion of toe, improved satisfaction, better pain control, and diminished recurrence of deformity. So in conclusion, overall, flexible forefoot deformities such as hallux varus, clawed hallux, hammer toes, and angular lesser toe deformities can be treated effectively with tendon transfers. And it's really based on the presentation of the flexible forefoot deformity. So you can use these as primary treatment for these tendon transfers or as adjuncts of bony procedures when they're components of fixed deformity. So thank you guys. Sorry again for going down like that.
Thank you very much. That was a very comprehensive, I would say, coverage of the forefoot deformities, and the topic covered by you was great. I have a question for you, Andrea.
Yeah.
For hallux varus, and I think we in India, I've seen more hallux varus than the whole time I spent almost 12 years in UK. We had hardly seen a non-iatrogenic, hallux varus. Even in your case, which you showed, was because of the post-surgical correction. But in India, we see a lot of hallux varus, maybe idiopathic or maybe rheumatoid as well. Now, what is there a cutoff where you would try to do these transfers, or would you just go ahead with a fusion? Like any numbers or
Well,
anything to guide?
there is not really a number for me. It actually depends on what the cause is, right? So if it's the morphology of the toe, you need to deal with the bony morphology of the toe. The key thing is it a flexible deformity? Is it a fixed deformity? Is there arthritis? Is there pain on reduction of the deformity? So if I think that the patient's painful on reduction of the deformity, then there's no point trying to save the toe. And that means that a first MTP fusion ends up being a very reproducible outcome for the patients. In addition, if I find that they have a lot of lesser drifts or lesser toe drift, where the lesser toes are really drifting into the first ray quite substantially, and I can't clear them or get them out very easily, I still think an MTP fusion is better. And then you might need to address the lesser toes by doing basilar lateral proximal phalanx osteotomies to clear them out of the way as being an option to deal with the problem. However, if it's a correctable deformity, no matter the size of it really, is not painful on correction, then I think you can actually look at doing a salvage of the toe. And that might mean that you might need to add bony adjuncts, such as rotational osteotomies of the metatarsal head or changing the metatarsal head, in addition to doing tendon type procedures for it. And actually working with Mark Meyerson, we've had a few congenital issues where I've treated the congenital toe with tendon transfers and pinning in younger kids, which I've actually seen as being non-iatrogenic. But in my practice, generally speaking, it's iatrogenic. And again, it ends up being a question of the way the patient presents, the bony anatomy, the soft tissue anatomy, and what the lesser toes are doing, and pain on reduction. And then when you add that whole picture, that gives you what you really need to do in terms of treatment.
Sure. Okay. One more question. One more question I wanted to ask you. I saw in one of your slides where you severe hallux valgus, you do an MTP fusion. Now, I've had few cases where in India, people present only when they have severe hallux valgus and then shit hallux valgus. You know what I mean?
Yeah.
And I have done fusions of the MTP joint, and after some time, you find a clawing of the IP joint. Have you noticed that?
Yeah, I have. I mean, that's a very, very difficult problem once you get that, because to treat that problem becomes very difficult. And then the question really is, did you put the MTP joint in the right position? Sometimes, if it's too elevated, what happens is that the patient uses the tip of the toe to bring the tip of the toe down because they're so used to feeling it on the floor. So as a result of that, they end up actually getting clawing. So it might be that we've over dorsiflexed the MTP joint as one of the reasons. So in that setting, I have sometimes done opening wedge osteotomies dorsally and put an opening wedge dorsal plate on. The problem is that sometimes that's not the issue, and they're so used to feeling their toe that they like to bring it down. And in that case, the only thing you can really do is do an IP joint fusion. So now you have a double fusion, which ends up being an issue. The bigger problem I have with that is if they sublux their proximal phalanx down, where you actually get that prominence and plantar pain under the proximal phalanx, and that's a real problem to deal with. So in that case, I have to do an IP joint fusion and bring that proximal phalanx back up in that sagittal plane in terms of like a translation, not just the angular correction, but an actual translation up, because they tend to sublux it down, and I find that they get that very strange pain under the proximal phalanx.
Sure. Question to all the panelists means I have had 3 cases of non-rheumatoid, almost like a windswept deformity, where you have a hallux valgus on one and hallux varus on another. Anybody has any thoughts on this, or have seen them non-rheumatoid? Hello.
Sorry, what was the
I haven't
question again?
I haven't seen that deformity in non-rheumatoids.
Yeah. Okay.
I have a good experience of hallux varus as part of the neglected club feet. And you can see even a video of a 24 years patient, neglected club feet left, you see, after 2 surgeries in early childhood. He had hallux varus and osteoarthritis of the talonavicular joint. So this video is available on my YouTube channel, Patiala Clubfoot Foundation. That is the channel. You can see that video, and the way I correct it in these cases is VY-plasty of the skin, and then
Sure.
capsulotomy of the medial joints. It's not only hallux varus, but there is a metatarsal varus also in these cases, and it's a complex part of the clubfoot. So capsulotomies and VY-plasty of the skin, and then putting in overcorrected position, fixing it with K-wire, and for at least 6 weeks. And it has been beautiful. You'll see that video, but I have good experience, and so many cases are there which I correct by these capsulotomies and VY-plasty of the skin and fixing with a K-wire through and through from the phalanges into the metatarsal and going into the, you see, back into the navicular and talus. Big K-wire, long K-wire, and it corrects the deformity very well. And
Thank you.
that video is one of the demonstrations. It is the whole surgical video is there with this description.
Thank you very much, Dr. Mittal, for sharing, Professor, for sharing your experience. Any questions or any comments before I move ahead with the next presenter? Okay, so we don't have any questions for the time being. May I invite David Richardson from Campbell Clinic, who will be talking on drop foot and bridal procedures. Dr. Richardson.
Great, thank you. See if I can everybody see that?
Yes, we can.
Well, I don't want you to. Hold on. Hold on just a second. I was not on the right slide. All right. Now I want you to. All right. Well, thank you. Those talks were absolutely excellent, and just really honored to be asked to be a part of this panel and to be talking to the Indian Foot and Ankle Society. So thank you, India, in general, for having me and for all that you have contributed to this subject in general. Thank you, Dr. Manat, and Eric also for asking and putting this together. India has contributed significantly to our understanding of neuropathy. And palsy, I would like to specifically mention Dr. Paul Brand, who worked in India from the late 40s to the mid 60s, and in collaboration with Indian physicians really advanced our knowledge of transfers of the paralytic hand and foot, working at the Christian Medical College in Vellore and the Leprosy Sanatorium. And there's a picture of Dr. Brand in his almost 20 years in India. So what is a bridal procedure? It's transfer the posterior tibial tendon to the dorsum of the midfoot. Usually it's through the interosseous membrane, and we'll discuss that later. And a transfer of the peroneus longus to the anterior compartment. This is a static transfer. This is not with its motor muscle unit, as we'll discuss as well. And a tritendinous weave in the anterior compartment composing the posterior tibialis posterior, peroneus longus, and tibialis anterior. And that's shown here. There's variations, subtle variations, but this is in general what a bridal procedure is the posterior tib through the interosseous membrane and attached to the, woven through the anterior tib. This is the tibialis anterior that stays at its native origin and insertion. Peroneus longus is tenedis to the brevis, shows the peroneus brevis. Peroneus longus is then transferred to the anterior compartment, and the posterior tib tendon is then brought through the tunnel in the whichever way you see fit. And we'll talk about that as well. So requirements for a bridal procedure is at least 4 out of 5 tibialis posterior strength. You have to have some flexor tendon strength in the posterior tib tendon, at least 4 over 5 gastroc strength. You need, again, to have some plantar flexion strength for this tendon, for this transfer to really be effective. You need an intact tibialis anterior and peroneus longus. Quickly, this history, Dr. Watkins described a posterior tib transfer through the interosseous membrane in 1954. Brand had a couple of reports on transfers in the paralytic hand and foot. Dr. Lipscomb and Sanchez used a triple arthrodesis, so stabilizing the hindfoot that we're going to discuss in a second as well. And then Riordan, along with Dr. Brand, in 1973 described posterior tib transfer with dual insertion by means of the anterior tib and the peroneus longus. And then Dr. Rodriguez modified this to have a direct insertion of the posterior tibial tendon into the medial cuneiform. So indications, there are multiple indications. They all involve a drop foot, and they all have to be thought of a bit differently. They all have a little bit different considerations. And so quickly, peripheral nerve injury, either common perineal or deep perineal, really has probably the most predictable outcomes with the bridal procedure. And this is really where it probably works the best, is with a traumatic nerve injury. L5 nerve root deficit also is likely to have a degree of active function, and this is a good indication for a bridal procedure as well. In spastic paralysis from upper motor neuron disease, the voluntary control is going to be unpredictable. It's difficult to really obtain good voluntary control in patients with spastic paralysis, although the results can still be good. Then in leprosy and polio, again, a lot of our understanding comes, especially from leprosy, comes from India. Remains a formidable therapeutic challenge in different areas of the world. There's significant benefit, and this has been published on really more than any other indication, leprosy and polio. These are really the studies, the best studies we have on a bridal procedure, leprosy and polio. Dr. Shah, who's very important to the foot and ankle orthopedic world in India and in the world in general, has reported on this. The sensory deficits in leprosy can lead to complications. That wasn't the point of this Dr. Shah's study, but he showed 80% achieved active dorsiflexion and 94% achieved near normal gait in his excellent study. Lumbar myelodysplasia, spinal dysraphism, as well as Friedreich's ataxia and muscular dystrophy. You have to be very careful in performing this procedure in those patients. These patients it's a broad spectrum of presentations and considerations. You need to have a multidisciplinary approach with these patients to achieve a good outcome. Anterior lateral compartment syndrome, often the bridal procedure function is just a tenodesis. Dorsiflexion can still be of great aid, but they often scar down. There's significant scarring, and so they don't get a lot of excursion in this patient population. Hereditary motor sensory neuropathies, the results are unpredictable due to the progressive nature of that disease, and oftentimes a hindfoot stabilization or at least hindfoot procedures need to be performed, whether they're calcaneal osteotomies, joint releases, etc. That needs to be performed along with the bridal procedure. Contraindications include an incomplete nerve injury that goes along with possible likelihood of an anterior compartment muscle strength recovery. Significant loss of strength, the contraindications would be significant loss, I meant to say loss, significant loss of strength of the gastroc or posterior tib muscle, significant scarring in the anterior compartment, or vascular insufficiency. Treatment for drop foot, quickly, heel cord stretching, bracing, arthrodesis, and posterior bone block. And what we're here to discuss is tendon transfer. So advantages of the bridal procedure: it can treat uniplanar and multiplanar deformities. Multiple etiologies are amenable to this treatment, and we discussed those above. And it's fairly predictable and has excellent satisfactory long-term results noted in different studies. Disadvantage, it is technically demanding, as Dr. Blumen and really all of the speakers have noted. Tendon transfers can be technically demanding for a number of reasons, including you can have multiple incisions, including the plantar incision that Vinod mentioned. The setting the tension can be difficult, as we've said over and over. This is a bit of an art. Potential loss of excursion. There can be injury to the superficial perineal nerve if it happened to be spared, if this only is a deep perineal nerve injury, which is fairly rare, but you have to consider this. And a calcaneal deformity can develop, especially if you have an aggressive heel cord lengthening or in patients with spasticity or myelodysplasia. And then, of course, bowstringing, depending on whether the posterior tibial tendon is transferred above or below the extensor retinaculum. Outcomes for spastic paralysis are unpredictable, as we've noted. And other than leprosy and CP, thanks to, in part to the work done in India, most of the studies have multiple etiologies, wide variations, limited numbers, and therefore most evidence is level 4. So considerations I want to run through quickly before I go through a case and present some clinical photographs. So do we have to worry about progressive flat foot? We are transferring a tendon that is important to prevent flat foot deformity. Insufficiency of the posterior tibial tendon can result in flat foot, as has been noted. So is that a concern? Bony fixation versus tenodesis, is that important? Relative strength after transfer, how much can we expect? Is transmembranous transfer of the posterior tibial tendon crucial, or can it be circumtibial? Posterior tibial transfer superficial or deep to the extensor retinaculum, which one is better? So quickly to run through these, progressive flat foot, the literature suggests this is really not a concern. Residual varus is more of a concern. There's been several studies to suggest that patients really do not go on to progressive flat foot. The static structures, the calcaneonavicular ligament, etc., really prevent a progressive flat foot in these patients. Bony fixation versus tenodesis. Bony fixation is more predictable and reproducible. Sometimes it's difficult to achieve, especially in certain parts of the world. It might be difficult to have suture anchors and tenodesis screws. As Vinod mentioned, we can perform bone tunnels, but this gets to be a little more difficult in the midfoot than it is in the calcaneus with an FHL transfer for Achilles reconstruction. However, good results are obtained with either technique, and that's been shown in studies. Both allow for early active dorsiflexion and with protected weight bearing. And Dr. Rodriguez showed that precise placement of the posterior tibial tendon really is not necessary, which allows for a tenodesis really to work fairly well in this patient population. So how much strength can be expected? Well, certainly not symmetric. And it depends on multiple factors, intra, and post-operative factors, as noted here. But restoration of dorsiflexion strength, about a third of normal, can be expected, as shown by Dr. Suhu, who also showed that function as daily activity and gait are satisfactorily improved, and patients are very happy with this procedure. So transmembranous versus circumferential transfer, really the balance of literature suggests that transmembranous transfer is the better way to go, and it results in more strength, better normal function, improved kinematics, and greater range of motion. Circumtibial transfer has more resistance to tendon gliding, less dorsiflexion, and produces a supination moment to the foot. Transfer superficial or deep to the extensor retinaculum. I do this depending on the patient. I have done it superficial and I do it deep, and I really think both of them have their place. Superficial to the retinaculum increases strength and improves kinematics. Deep to the retinaculum certainly avoids bowstringing, and I've had colleagues say it just drives them crazy with the bowstringing, and I wonder how often they've done this to say that, because that's not been my experience. It's not as problematic as you might imagine with the bowstring, but deep to the retinaculum does avoid bowstringing and might improve range of motion of the ankle as well. So expectations depends on the etiology, as we've already mentioned, but it should be a brace-free gait, balanced foot, normal walking speed and stride length on even ground, but they're going to have significant limitation of motion at the ankle. Plantar flexion is more effective than dorsiflexion. They really get pretty locked down in terms of their plantar flexion, and they're going to have difficulty with running or walking on uneven ground. So post-operatively, I have them non-weight bearing for 5 weeks in a splint or a cast, touchdown weight bearing in a boot until 8 weeks, and then starting therapy. They wear an AFO until 6 months post-operatively. I ask them beforehand to wear an AFO. I just don't want this transfer to stretch out, and I think this helps prevent that. They normally come to me having been in the brace for years, so they don't mind wearing it a bit longer. Out of the boot and a lace-up ankle brace at 6 months, and then brace-free at 9 months. If I might, as my clinical pictures are with the case, I'm going to quickly present my case to run through this technique. This is a 39-year-old stabbed in the buttock 3 years prior to presentation, partial sciatic nerve injury that resulted in common peroneal nerve palsy. Really didn't have significant medical history. He had obviously very weak extensors and everters, but he was a bit weak in his gastroc and tibialis posterior as well, given this knife injury. So he wore his AFO for 2 years and wanted to be brace free. You can see here that he has significant gastroc atrophy. His gastroc soleus complex was really atrophied and gave him a little bit of weakness. He really had maintained his dorsiflexion quite well. His range of motion, well, not active dorsiflexion, but he really is not significantly plantar flexed, even just sitting without me pushing. But you can see where he is dorsiflexing his right foot, his contralateral ankle, and you can see the tibialis anterior bowing here. And he really has no dorsiflexion strength in his left foot. But he does have neutral dorsiflexion with my gentle dorsiflexion push. So incisions, there are normally 7 incisions. I tell the patient they're going to have 7 fairly small incisions. It's pretty standard for me unless I'm doing other procedures. 2 medially, 2 laterally, 2 anteriorly, and 1 posteriorly, because I almost always need to perform some type of gastroc recession or a tendo-Achilles lengthening depending on the silver skull test. So gastroc recession is based on silver skull. This patient, I performed a gastroc recession. This is harvest of the peroneus longus, which is a static transfer. You can see I have transected the peroneus longus from its muscle tendon unit, and then I tenodiced the peroneus brevis, peroneus longus to the peroneus brevis. Then I harvest the posterior tibial tendon. I always put a vessel loop around the neurovascular bundle so everyone's aware throughout the case of where this is. Make an incision of the anterior compartment. This, I make an incision, I get my knife and really create a good gap in the interosseous membrane. You do have to be careful of the branch of the peroneal artery, but if you do this carefully, it's really not too much of a concern, or as much of a concern as I thought it might be at the beginning of my career. I usually use a long-handled hemostat or a long-handled grasper. This is the peroneus longus, so it's subcuticular, but through the interosseous membrane, you can use the same instrument. This is now showing the peroneus longus, peroneus brevis, and the anterior muscle belly, the tibialis anterior. I go ahead and weave my tendons through, but don't tie them down other than the longus. I can tension my longus at this point because I can push up on I can create a neutral dorsiflexion angle to the ankle. And I go ahead and suture my longus down, but leave my peroneus my posterior tibial tendon free until I've tensioned this in the bone tunnel. So this patient, I did take superficial. I took my posterior tibial transfer superficial to the retinaculum here, and I'll show that in a bit. In part because he was already weak, and so I wanted the greatest strength that I could get in this patient. He was already a bit weak in his flexors. I created my bone tunnel. In this case, it was in the middle cuneiform, as shown here. And then I held this with appropriate tensioning with a tenodesis screw. And I do essentially everything that Dr. Blumen mentioned. I do a tenodesis screw, and then beside it, I use a suture anchor to suture in. And I do an endo button that I'm about, not really, I sew it over a bolster, but same principle as an endo button. And then perform a tight closure of the anterior compartment as seen here. And that's at an early follow-up. I just wanted to show that I'd also sew the posterior tibial tendon as I pull it through the middle cuneiform. I sew it over a bolster here, and I could just cut that out at post-operatively. I usually cut that out at 5 weeks and just allow the suture to retract. I do put them in a dorsiflexion splint. And this is a couple of years post-operatively. You can see the bowstringing. He never mentioned that to me. As a matter of fact, I even asked about it because I had been asked about it in doing this, and he had stated that it's just not a concern, which has been my experience as well with these patients. But he did very well with this. And then I did not get a pre and post-operative ambulation video of him, but just to show a couple of cases. This is a patient that really has a good range of motion after a after a bridal procedure. And here's one last patient, just good ambulation with after a bridal procedure, brace free. She is a couple of years after a bridal procedure and has done very well and happy with her results. But note, I did find that article, so I threw it in here real fast. This is the JBJS article that I was referring to. It's actually forefoot, but hopefully that can be translated to the midfoot as well. But it is a forefoot plantar incisions. But well, thank everybody for having me.
Thank you very much, David. Fantastic presentation and very comprehensive. I think really great. Any questions from anybody from the panelists? No, crystal clear. Okay. So while people are looking at the thoughts, may I invite Dr. Mittal?
Yes.
Yes,
I
Dr.
just
Mittal.
want to ask you, when you do this transfer through the interosseous membrane, does it not get adherent with the interosseous membrane, and any experience of that? Tendon getting adherent?
Yes, sir. So as we often do, I show my, I take a video, and that's the video I end up having is the video of excellent range of motion. And because that's, in clinic, I'm so impressed with myself that I take a video. And so that is not what I normally get, to be honest. That's more motion than I normally have. They usually get somewhat adherent. I've tried to, I used to shut them down for 8 weeks. I worry about them, about motion and pulling out early. And now I start motion at 5 weeks. And I think that has helped, having a little earlier range of motion to prevent that adherence. But yes, sir, that can occur.
Can I ask you, David, I saw you almost put them in a plaster for almost 6 weeks and put them in an AFO brace for 6 months. Is that correct?
Yes, I put them in a splint or cast for 5 weeks. I used to do it for 8 weeks, but yes, I do it for 5 weeks now.
Okay, and then but put them in a foot drop splint for almost 6 months?
That's right. Now, I do have them taking that out and working on range of motion, and they're not sleeping in that normally, but I do have them walking in it so they don't stretch out their transfer.
Sure. Okay. One more question before we proceed for the cases. what do you do if you have a flail ankle? And we do quite a few, like you saw the sciatic nerve palsy, and usually if all the muscles around the ankle are flail, he is balanced, but it's flail. Any role of tendon transfers or anything where you can use it, any of the tendons for tenodesis? And the question is to all the panelists.
I'm going to present a case. So my case is this. If you
Okay,
want, you can
okay.
discuss.
So I won't take the thunder out of you, Rajiv. So we'll discuss that later. So hold the thoughts with all the panelists. Sorry about that, Rajiv. May I invite Professor Mittal sir, if you can start sharing your case. So we'll have around 3 to 4 minutes for the case, and then around 6 to 7 minutes for the discussion.
Okay, bhai.
If you go at the bottom and do share screen.
Okay, कितने अपने WhatsApp?
While you're there, both Andrea and David, there are some questions in the Q&A section.
Yes.
If you'd be kind enough to just look at them and answer it appropriately, please.
Shut the ठीक है. Okay. I express my gratitude to the organizers for inviting me for this wonderful webinar. Well, I'll be talking about the neglected clubfoot because I have researched this area for almost 60 years now, and this is quite common, and there's 95% relapse rate reported in literature under various brand names. I published a very comprehensive article in International Orthopedics in 2018 and put all these neglected deformities, brand names under one generic name, that is extreme clubfoot deformities. Now, this has been a need-based and evidence-based three-phase research. First phase, you see, took about 30 years. And then the next two phases, need-based, and evolved an all-inclusive triple R 4-in-1 surgical concept. There have been innumerable global presentations and publications. Various tendon procedures are usual to be used in clubfoot, but with newer concept. Tendon transfers, tenotomies, lengthening, sliding proximally or distally. You see, tendon engineering, as Professor Eric had said. You see, this is what is tendon engineering. So they have been, you see, very frequently in every case, tendon and muscle procedures have to be done. But you see, because the most important discovery in this research has been shortening of the skin, tight skin. You see, unless that is first lengthened, it is impossible to achieve any correction. The soft tissue corrections, muscles, ligaments, etc., and then the osseous or the arthroidal corrections. Now, these are various publications. You see, there are 3 in International Orthopedics, and the other one in the Asia Pacific, this foot surgery, and then there are other, you see, recent publication. The most recent, published only, you see, in May, is each clubfoot is different, and I have named it as mother of all clubfoot inventions. So this is an incredible unity in diversity with cure all fusion 4-in-1 surgical concept. This is, you see, appearing in a couple of days. Now, this patient is 6 years female, clubfoot with multiple congenital constriction bands. You see, over enthusiasm with Ponseti technique is very common. You see, everybody is doing in his own way without following what Ponseti has said. And that is why Ponseti has himself reported, you see, tremendous amount of relapses in his publications. And there are so many reports, even up to 95% relapses have been reported with, you see, various, you see, brand named neglected club feet. Now, this patient was given Ponseti cast for 1.5 years, for 1 year. At the age of 1 year, it was started and continued for 1 year. Heel cut anatomy was done at 2.5 years, and weekly 10 casts were given in full dorsiflexion. You see, it is unfortunate that Ponseti's protocol is completely neglected because it is laborious and requires commitment. 5 hours, that is right age, right type of deformity, right protocol, you see, right bracing and right follow-up. These are the 5 things which are quite laborious for caregivers as well as you see, care receivers. So unless his protocol is followed, you see, Ponseti is never advised his technique to be used in extreme deformities or you see, severe and rigid deformities. But people are still doing it and landing into trouble. This is a unique complication. I am reporting it for the first time, calcaneovarus deformity in a you see this, you see, there's a Ponseti scar over there at the heel cord anatomy, and this patient developed a calcaneovarus deformity, and there's a big callosity over there. This is only the weight bearing area of the foot, and you can see the congenital amputation, you see, and hourglass constrictions on both sides. This is the dorsiflexion on the affected side. The tendon is, there's no, you see, tendon attachment at the heel, and it has receded proximally. And this is the X-ray, the medial malleus is just touching the navicular. And these are the footprints. You see the Ponseti scar over there, then calcaneus deformity, and hourglass the constriction band, both sides. Now, there's a tibialis anterior contracture in this case, fixed dorsiflexion deformity. So, this tendon was lengthened, Z-plasty was done, anterior capsulotomy of the ankle joint was done, and this is the heel cord. You see, there's no tendon in this area, and there's a, you see, dense adhesion over there. So what was done? You see, when you freshen this tendon, there was so much of gap there. So what I did was, I reflected a sleeve of the tendon from the proximal area and then converted it into a tube and then put it in the gap, anchored it to the heel and then anchored it to the proximal end. And this is the closure. This wound, you see, could not be closed, and so a VY plasty was done over here, and that is the result. You see, there is a complete healing, and this is the correction. You see the active dorsiflexion and the patient standing on heel on the forefoot. So this is the result. Follow up at 1.25 year. You can see a enlarged view. This is the VY plasty, and Z plasty was also done in this case. And this is the scar of the tibialis anterior lengthened over there, and anterior capsulotomy. And you see this picture. That is another case. 17 years female, 2 relapses, grade 3 extreme deformity, painful, and that is what it is. You see, hyperextended toes. You see, you have seen in earlier presentation. You see, this is what the deformity was. You see the scar over there. Then you see adherent scars of 2 earlier surgeries. And if you just, you see, pull it there, you see this scar. And so this is what we found. The tendon completely adherent, and you see what happens if you do heel cut anatomy. The scar doesn't grow, but the bones grow. So there is going to be a relapse in these cases. Heel cord anatomy does more harm than good, you see, because of the reason. This Ponseti himself has commented in his writings. and people still are doing without understanding the real Ponseti technique. So you can see the condition of the, you see, tendon over there. I've even done the histopathology. There's scar and scar, you see, irregular scar over there. Everybody knows that the scar once contracts, it doesn't grow, but the bones naturally will grow. So the left is bound to be there. So this is again the same thing. A sleeve of tendon from the musculotendinous area and the proximal part was raised and put in there. So this patient, you see, I operated. I have been designated as emeritus professor in the government medical college over here, and I am permitted to, you see, promote research, academics, and poor free surgeries. This was, you see, a class of the postgraduate students, pre-operative, and then it was covered by the Tribune newspaper. And this is only after 3 weeks. You see this complicated, you see, VY-plasty, Z-plasty, and rotation flap. You see, there's a nature's miracle under the skin. There are, you see, scores of plastic surgery journals which show the evidence. There is a nature's miracle. Innumerable perforators from all levels, from the deeper to the superficial tissue fascia. And if you are careful, remain superficial to the superficial fascia and don't injure this perforators, you can go with, you see, eyes folded blindly and you will never get necrosis of the skin. You see, this is what I am showing you just after 3 weeks. See the healing of the skin and the complicated incision. You see, it's a nature's marvel. So this is what it is. The multiple KYs are put in. There's one there, and on the lateral side, and there's one on the dorsum also. This patient is very poor from Saharanpur of Uttar Pradesh, and they cannot afford, but I have her telephone number. I have talked many times, you see, and they're very happy. Now she will want to come for that other foot also. We have to arrange for the money so that we can operate upon the second foot also. You see, it's a real treat to treat such cases, and you get real pleasure.
Thank you.
So you see, this is rotation, Z-plasty, VY-plasty, and multiple K-wires. So these are the plastic surgery references. These 4 plastic procedures, rotation, Z-plasty, VY-plasty, and fillet flap, have been used for the first time by any surgeons. You see, not only not even the plastic surgeon. 4 the plastic procedures combined in one incision. So these are the various references. Bhattacharya has done a lot of work on these, you see, perforators and microcirculation under the skin. It's indeed, you see, marvelous, you see. So these are various references. So this is you can see the patient is walking on the, you see, head of the metatarsals, and the tibia is parallel with the metatarsals. This is the direction, and you see he is walking on these head of the metatarsals. So this is what it is. You see, I will show you just this video pre-operative. And this is the post-operative. Two surgeries in each foot.
So what was done for the patient, sir?
You see, this is what I told you, the rotation, Z-plasty, this is must, you see, this is a prerequisite. Unless you lengthen the skin, it is impossible to achieve deeper corrections. See, that is what it is. See,
okay.
This patient also had similar procedure. He had Ponseti also in early childhood. Okay. So similar procedure was done in this case.
And what about any tendon transfers or any bony correction, sir?
Bony correction, of course. Otherwise, it's impossible to achieve this. But you see, the patient is walking on the metatarsal heads, and you see this video of the present video. This is another patient. See this deformity and this callosity, and this I just wanted to show you this slide because this is the tibialis posterior. tibialis posterior has a fan-shaped insertion in the sole of the foot, 9 insertions, 6 tarsals, 3 middle metatarsals. You release all these insertions and let it slide proximally. It gets attached proximally so that the partial function of the tibialis posterior is also retained and the deformity gets corrected. You see, the foot just opens out. You see, it is like a closed fist and it opens out when you release these 9 insertions. And then, of course, uh, there's at least 20 deeper steps which you have to carry out. It's difficult to tell, you see, because of this paucity of time.
Sure.
So this
Okay.
is what it is. This is what it is. This patient usually had these 3 TH graft, a VY plasty, Z plasty, and you see all these 4 procedures. So
Okay. Thank you so much, sir. Thank you. I would really like to stop you there, sir. A really great cases. I would like till if you
this
can
is
stop.
three Ponseti heel scars in this case. 3 Ponseti heel cotinotomies was done, and you see similar calcaneovarus deformities there.
Thank you so much. Thank you so much, sir. So if you don't mind, stop sharing your screen while we are there. Any questions from any panelists or any comments, sir? Vinod, Andrea,
So
David, Rick?
Marvelous presentation, I must say. Though these kind of challenging cases, I don't know whether anywhere else in the Western world you will find these are severe deformities involving all structures, and Dr. Mittal has produced fantastic results with his surgical skills.
Unless you correct the skin contracture, it will not be possible to correct the deeper deformity. And you have to deal with the muscles, tendons, ligaments, the capsules, and even the bones, joints, everything. You see, it's a total correction.
Very great.
And you
Very
get a good looking, longer, without fusion feet in majority of the cases. I don't fuse.
I thought it was an excellent presentation. That is incredibly severe deformity, and you have some excellent post-operative correction following that. I would, with some of those very severe deformities that you showed, I might tend towards a telectomy. I'm not sure I would know how else to get them around without just performing a talectomy. And I'm impressed with your results.
excellent. If there are no questions, can I invite Dr. Rajiv Vora, who's a president in the Indian Foot and Ankle Society, to present and give a talk? Rajiv, sir.
I'm trying to share the screen.
Mm-hmm.
So mine is a very small talk. It is not, I don't know why it is not showing.
Yeah, we can see. You need to share your presentation, not your Zoom screen.
Okay. Can you see it now?
We can see your, yeah.
Battery चली गई. But it takes long.
Okay. That's it.
Don't they know?
So mine is a very short presentation. We are overshooting the time, so I'm not going to take much time. So this is just a continuation of what Dr. Richardson said, and you asked the question that if there is a flail foot, what you are going to do. So he did not mention this indication in his talk on the bridal procedure. So it is just a continuation of the talk that all I want to show is that this procedure works even in the presence of the flail foot. So we had a 45-year male with an injection history in the gluteal region, and after that there was intense pain and he developed weakness of the lower limb with the loss of power around the foot and ankle and some inability to flex the knee. And the power around the knee improved with time, but no recovery was seen, in the foot. Clinical examination had no medical issues. Unfortunately, he could go around to 5 to 10 degree of dorsiflexion, and there were no skin problems, no medical problems. So it was basically a flail foot. And should I ask panelists what are they doing, or should I go ahead because we are running short of time? So all I want to convey is that this bridal procedure can be used even in these situations, and we have done in 3 to 4 cases, and we are very happy. Basically, okay, I'll start with the video how I do it, but this has been very well discussed by Richardson. Initially, we were worried. We were doing tibialis posterior transfer only for the tenure suspension. But then in certain cases, we found that due to, as the time passed, they gave away, the dorsiflexion was lost. But with this procedure, we have followed these patients for some time, and they are done. This is exactly what the anterior incision to the interosseous membrane. We are just trying to, this is just the video of all the things. This is tibialis posterior, which was harvested, has been taken into the anterior incision. Now we are trying to trace the peroneus longus here, and this is how I distinguish between the peroneus longus and the peroneus brevis. Then you see, this is how you are sure that when you pull it, you are seeing there is a flexion of the first metatarsal. So once you have defined your peroneus longus, you cut it and harvest this again distally, and then again using a long forceps, you bring it into the anterior incision. And I keep on closing the incisions. Just if you see, all the incisions are closed simultaneously. I ask my assistant to keep on closing the incision so that there is a less rate of infection. Once this is done, there's a slit which is made in the tibialis anterior as shown by Dr. Richardson, and then it is the middle cuneiform used here and just verified on image intensifier, and then this is the drill which is used for now. The tibialis posterior is retrieved into the distal incision, and then it will, you see, this is the amount of the, we have not done any lengthening. Fortunately, the patient had this much of excursion, so we never had to do it. And then by just passing, this is how the tension is achieved. You can see actually the tendon passing into the hole, and then it is fixed with a interference screw. Once it is done, then we suture the peroneus tendon. And this is, you see, the final, basically, what you see. So my question to the panelist is, once again, what are their options for the flail foot?
Okay. Excellent presentation, Dr. Rajiv. Open for discussion. So
Dr. Vora, I think fantastic. It looked well balanced, and I think that the easy answer in these cases, as you mentioned, is one of your options is to perform a pan-talar or a TTC fusion, and I think that for many surgeons that's easier because it's you don't have to think as hard, quite frankly. And I think what you did takes an incredible amount of thought and consideration and planning with the patient. And I wonder, I really think that these type of procedures will benefit the patient in the longer term. Certainly, you can get a good result with a TTC fusion or a pan-talar fusion, but I think what we need to think about is really what are the consequences for the patient in terms of stress risers and stress fractures and midfoot arthritis that will develop later on. Almost assuredly, if we do these extensive fusions, by doing what you did, we are including a physiologic shock absorber in the whole construct in multiple joints, which will probably lead to longevity of the remaining joints of the foot and the ankle, because you took care and did a more extensive, more thoughtful procedure.
So
I have to
it's-
agree with
and-
Eric. Personally, I think that the key here is to, if they're a young presenting patient,
Yeah.
if you can do joint presentation with such a thoughtful procedure, I think that really is the key in terms of long-term options. I think once you go into midfoot arthritis, these patients have minimal options and their outcome diminishes significantly. So I think this is a wonderful approach. Sometimes I'll add a scope gastroc recession to it, but other than that, this is lovely. Thank you.
We do
Question I
we do
have
add a gastroc recession when there
Okay.
is where there's a contracture, Aquinas contracture. But in
Perfect.
this patient, it was just 1.5-year-old injury, so there wasn't any contracture, so we didn't go for it. Apart from that,
Ironically, I have the exact same case that's coming into my clinic in a week. So thank you for helping me.
so let's see how it works.
Yes,
We
Yeah.
even,
Thank you.
we even asked the patients to use AFO for some time, but I have seen people coming in clinic without AFO, and even then they are happy.
Rajiv,
yes, Vinod.
I have a question. What's the longest time follow-up do you have? Because
5 years.
honestly, 5 years,
Yes.
5 years, and they haven't, like
No,
dropped.
no.
That's you should use that. I think
We saw this dropping when we were using only posterior tibial tendon. So that is why I had even used only transferring the posterior tibial tendon as a tenodesis. But those patients actually lost the dorsiflexion after some time. But since I started using this procedure, they are very happy. That was all of it.
So my question is for flail ankles, right? Flail ankles and the whole flail foot. Does everybody agree that I think a bridle would be a better option and a salvageable option in the initial phase to try it? And of course, if that fails, you can always go ahead and do an pan-talar arthrodesis or whatever you want. Would everybody agree? And if that is the case, any tips and tricks for flail ankle versus a drop foot or anything else?
I would say just be very careful with your tensioning in a flail ankle. You can, I would actually worry the other way, not them losing dorsiflexion, but I wouldn't over dorsiflex them. I think you could give them a calcaneal gait
जाना तो चले जाओ बेशक
and end up with a
Huh.
calcaneal gait in this situation. Fat pad ulceration can be devastating, as we all know, pretty quickly.
I also
Sure.
I think that most people realize how much technical expertise is required for this, much more than a retrograde nail or a pan-talar fusion, in my opinion. So I think that going back again to those principles, and there are some patients who may not want this, may not need this. Healthcare system and the team that they've got may not be technically capable of pulling this off. But all of those things being equal, if you have those components, then I agree. I think doing this initially, being careful of what Dr. Richardson is talking about, is a very, very good option.
Good.
Yeah, I agree.
Okay, last questions before we move to Dr. Ajoy. Rajiv,
Yep.
have you a question from Kiran Patel? Have you thought of combining this with Lambri Nudi as soft tissue stretching on long run is inevitable? Any thoughts on that?
No, I'll leave the fusion procedures for future because it is just a 4 or 5 years follow-up, 5 years. So I never know what is going to happen. So I just leave the fusion procedures for later on. So until now, I've been very happy with this procedure. So I don't know, maybe if I have to do a fusion, then I'll plan the whole fusions together instead of doing it one go.
Fantastic. Thank you very much. If you can stop sharing your screen, and I invite Dr. Ajoy. Dr. Ajoy is the secretary of Indian Foot and Ankle Society. Ajoy, please go ahead.
I'm trying to do that. I'm trying to share my screen. And there we are.
We used to do fusions now. Oh, okay. Ajay is here.
Yeah. Okay. Visible? Audible? Okay. A very simple case, nothing much, nothing very fancy in this, just that we could. Okay, this is a 24-year-old male. He was having multiple exostosis, and this is the reason he had gone in for an excision. About 6 years prior to my seeing him, he had got it removed, and especially the one on the fibular exostosis had led to a foot drop soon after, and it was detected. And after that, he had regularly been using an AFO, and which is one of the reasons probably he came to me in a good shape and not much of a difficulty. So this is what I generally do. I prefer to use the tibialis posterior. I take it off from the navicular. There's this very short video which I have it. Though I didn't take it intra-op, this is a cadaver dissection which I done. So that's the incision which I do take. That's and the navicular. And that's what I do. I take a deeper incision, and once that incision is done, identify the tendon from there, take a tag onto that, identify the tendon just behind the crest of the tibia proximally, and from there just hook it out, isolate the tibialis posterior, and that's the tendon which is available. So once I've done that, I make an incision on the dorsal aspect of the foot, somewhere or the third metatarsal, the base third metatarsal, or sometimes even over the middle cuneiform. And I don't use the tunnelers anymore. I just had shown that for the sake of class which I was supposed to take. Dorsal incision there, I don't generally take it from there. I'm able to bring it out from here directly without doing this. If I need to do the intraosseous, I would definitely take that, but I prefer to do the circumtibial, and I bring it out here and pass it with a guide wire and drill it and pull the tendon down. So that's what I do. I got the tibial posterior tendon out there. That's the drill hole which I identified. Okay, I use the third metatarsal base, or I sometimes use the intermediate cuneiform in these cases, and pull it out. And what I do is a very simplistic way of tying this. I don't spend any money on it at all. Just a tendon which is held down by means of an ethibond and brought down and tied over a simple button, a button which we use from our shirt. So a simple button like that, and over a gauze padding, and tie it up with the adequate tension and leave it there. I keep them in a plaster for about 6 weeks, which is what I did in this case also. And for the very first time, I found that maybe a complication, I would call it, wherein the button had actually gone in a little. This patient had a foot which was very, very soft. The the plantar aspect was extremely soft compared to the others, and he had just a sinking in and a skin depression which had formed over there. Did not have a picture of that, but when he had come in, this was less than 3 months, almost 6 weeks, he was already doing this. He could range of movement, and he was walking this way with a gait like that. He still was trying to avoid the pressure point which had come in from the button which was there. And 6 months, exactly 6 months, in the month of November 2018, when I just reviewed him, you could see that the whole plantar aspect of the skin had healed up. So this is where the tendon had come in through, and that's where the button was in. And that's the movements which he was, that's the scars which have healed up, just 3 incision scar. He was walking very comfortably, and he did, so that's the no AFOs, no nothing, very happy to be walking, wearing normal shoes, and age 24, that's what one wants. And that's the dorsiflexion which he was able to achieve completely. Okay. And the amount of eversion that was not very appreciable. I think probably couldn't get any eversion. Of course, I didn't do anything for the eversion at all, so I don't expect him to have any eversion. So that's about it. So very simple, straightforward case.
Okay, but a lot of things to discuss. I think it was a very good case, Ajay. Yeah, sorry, you were saying something, Ajay?
No, nothing at all.
Okay. Any comments? Anything? From the
Doctor,
panelists?
Dr. Manat, I apologize. I'm on call today, and the operating room is killing me. I'm gonna have to
Sure.
jump off, and I apologize. But thank everyone for inviting me, and it's been an excellent discussion. I've learned a lot.
Thank you, David.
Thank you,
Thank you.
David. Thank you very much.
Thank you very much, David. Thank you so much.
Thank you.
Really
very much.
appreciate your time.
Thanks, David.
Okay.
Okay, Pradeep, I have a question. You know,
Yes.
when you're taking off the posterior tibial tendon for all of you guys, how much of a tendon do you take off? Do you take off the whole of tendon? Do you take out part of the tendon, 1/3, half? Do you worry about them getting into posterior tibial tendon dysfunction? Well, I mean, the flat foot deformity later on. Do you change any practice with a cavus foot versus a flat foot?
So before that, one question, which, and I've had in the situation, the last time I did a tip push transfer for a drop foot, I could not get enough length. I don't know why. I actually take the tendon and take the periosteum sleeve as well. Have you had a situation, and this is a question to everybody, have you had a situation where you've not got enough length? And if you have, what is the cause of it? And how do you go about treating it?
Can I add something,
Yes, Raj.
Manoj? What is the cause of it? I don't have much of a solution to that. But I had one or two opportunities when this was the problem. So in these cases, what I do is I just slit the tendons into two halves distally. One half I attach to the tibialis anterior. That is, tendon to tendon suturing, as Blumenus said. And then another half is again split into two halves. One half goes into the EHL, the other half go into the EDL. So actually there are four anchorings at the four, so they're just complementing each other. So this is, and then you get a very good, even if you have a smaller length, you can, and it has been described in leprosy that there you can do a tendon to tendon sutures, and I have found them a very simple solution without much of money to the patients. I don't know about
Srinivasan's procedure. Srinivasan's procedure. I think that's what we used
I
to
don't,
call it.
I don't remember.
So that was my other question as well. Like, I know the fact that when I do my transfers, the tip post, putting it anteriorly, I straight away take the whole tendon and put it in the middle cuneiform. Okay, I like it because it's a bony thing. I really know I have got a good attachment. I can get a good dorsiflexion because that's what the patient wants. Now I know the fact, and I've had quite a few who go to the plastic surgeon for tendon transfers, where the plastic surgeon does explain that he will do 3 slips, 4 slips, give it to EDL, EHL, and everything. Does it really matter? Question to the panelist.
No, it's the situation where you're saying that you never had a length. I have just
So
given
this is
the
a salvage.
answer
It's a
I have
salvage
given
option.
the answer to that question.
Sure. What you're saying is, if you would have length, you would go straight away into the medial cuneiform and fix it. If you do not have the length, then you would do this.
Cuneiform is dependent what is the balance between the inverters and the inverters. It is not
course.
always middle, it's not
Yep.
always lateral. But
Sure.
definitely that is what I am going to do in those cases. And
Sure.
sometimes the patients are really, I have done in a very one or two cases where they're very particular that they also want to get movements of the great toe as well as the lesser toe. In these cases, what you can do is when you're harvesting the posterior tibial tendon, you can harvest the FDL also along with it. And then you can transfer it through the transmembranous route into the interior compartment and suture that FDL into
Must.
EHL into EHL and EDL.
Sure. Okay. Vinod, Eric, Andrea, thoughts?
So
Yeah,
I think the length issue is very important, especially with the posterior tibial tendon. And with the routing of the posterior tibial tendon, you can either go circumtibia or transmembranous. I don't have a good answer for it, but I don't know which will give you more length. But I have a feeling, since I've done both, is that they're both about the same. the one thing that I would direct you to, or might suggest, is in a case, two suggestions. If you come up with a situation where there's too little length, one thing you can do in just in planning this out is also to, instead of taking the tendon right at the interface, take a bit of bone with the tendon. And if you're dealing with the posterior tibial tendon, you can take a bit of the medial pole of the navicular with it. And it does make the transfer a little more difficult to do because you have that piece of bone with you, but it does give you a little bit of length, and then you actually get some bone-to-bone healing if you're doing your transfer through a tunnel, or if you're going to fix it to the cortex of the bone. The other thing that I've found that I've had to do is there are different suture suspensory devices that are available now. One is the type that they use for repairs of distal biceps that can easily be modified for a tendon transfer about the foot and the ankle. And if you really are in a difficult position, I've rigged up a similar device just from a tightrope that you can use for syndesmosis. It takes a little bit of time, but it can save you from not having enough length, and it ends up being something like a suture button that you put on the plantar cortex of the foot. And so so I think that those are options in terms of length. One last comment that I'd like to make on this case is that I think this is a great example how that we can't totally forsake out-of-phase transfers. This is clearly an out-of-phase transfer, but you can see how well that out-of-phase transfer worked in this patient. So certainly something that can be done, and we can't, we aim for the in-phase transfer, but this is a great example of how out-of-phase transfer worked wonderfully.
Sure. And also, just on that point, Eric, how long does it take for the patient to really work on these out-of-phase transfers? And Ayojoy as well, probably.
Yeah. So that's a great point, and I think that's another. These situations and these surgeries and conditions are difficult to research because there are few and they're very heterogeneous. But I do feel that there is a difference. Some people are able to work with physiotherapy and rework their circuitry to make this effective, whereas some it's an utter failure. And I don't know what contributes to that difference.
I think it's interesting to see.
I think so. If we start off, preoperatively, if we just start off with some amount of strengthening, if we start off with the tibialis posterior strengthening exercises and just try to get them up, at least passively dorsiflexing it, I think these are the kind of patients who do well. By about 3 months or so, they're able to do a complete dorsiflexion.
Sure. Anja, sorry, you were saying something.
No, there's no problem. I just said I think I agree with Eric that sometimes you just don't know what prognosticates success in some of these patients. You do the similar procedure, tension similarly, yet you don't always have the same outcome, which is quite interesting.
Yeah.
The one thing that I do just to get more length is, instead of just taking it off the insertion on the, and I actually like Eric's idea of a bone piece, but I tend to go even more distal on the plantar medial foot and take as many of those bands as I can to get my length. And I to date have not had a problem going under the extensor retinaculum or going to the perineals. But on the perineals, I do more of a suspensory method where actually I'll tether into the fifth metatarsal base and then do a side to side. Whereas if I'm going to the midfoot, I find that it's no problem as long as you get good length. And then the only thing I can just warn is make sure you always have a backup plan to your fixation, because your best intentions are to, do your interference screw and then everything goes badly. Make sure you have everything, there, everything from potentially having a suture anchor to transosseous type sutures that you can augment to potentially a button on the bottom of the foot.
A shirt button.
Yeah. I've used
it's very simple. You have also, okay.
Have it all.
Have it all.
I screwed it up every which way. So make sure you have the backups.
Yeah.
But I really wonder whether before harvesting whether your length is short or not.
You don't know. I don't think so.
So that is what I'm. How you make the decision that this I'm going to take bone along with it, because
No, but
Yeah,
you don't know.
I mean, for me, I think you want to go. I try to go distal to the navicular. I like the idea of the bone though, but I yet haven't had a problem with length so far. But I'm really aggressive, and I probably maybe take too much, knowing me. But
I realized only after taking the tendon that my tendon is short. I could never make.
Like Andrea, I see, I go way inside the foot. You see, so that's, I think, if you go deeper into the foot and follow the tendon as far as possible in the posterior
that's what I
tibial
do too.
and
And-
then
and that- and-
so,
And that brings to the point, you know, everybody says small incision, but I think when you're harvesting your tip
No.
post, I think
Big
bigger
incision.
incision,
No, it has to be.
bigger
It's always a
incision,
generous incision.
yes. And instead of these small 7 or 4, no. So I think that's what I have gone bigger on your tip post, harvested good, and then yes, you can work on with the smaller incisions.
Yes, I certainly agree. It is harvesting which is more important. After that, you can go all through the short and such.
Correct. Great.
Go big or stay home.
Okay.
Okay,
Anything?
stay safe, stay home, stay healthy. That is all. Corona times. That is all I wish.
I think there are only 33 participants now. Then I think before we are the only ones left, I think maybe we should stop.
I think, yeah, I agree with you. Marathon session here.
Yeah.
And
Yeah.
thanks, Andrea, in person. Now we are meeting each other for contributing the chapter. We'll be just.
Hello.
Yeah.
Hello. Sorry. Yeah, go on.
I don't know. I just wanted to just thank Andrea and Vinod for contributing those two chapters. We'll be coming up with that book within 4 or 5 months. So we are just working on
Thank you very much, guys. Appreciate it.
it. Thank you. Very
Thank you. Thank you.
Pradeep,
Thank you.
great job. Great job. This was a lot of fun. I think we should do it again sometime.
Sure,
Thank
of course.
Yes,
And
I
I
agree.
look forward to meeting you all in person. Hopefully, I can come down at some point. It would be amazing.
We will.
Hopefully.
Once again, thank you very much, Eric,
Thank you, guys.
Vinod, Andrea,
It's a
Rajiv,
pleasure meeting all of you.
and Mittal sir.
Yes,
Thank you.
Professor Mittal, thank you so much.
it's a
Thank
pleasure meeting you.
Guys,
Thank you so
for
much.
putting up with my bad connection. Thank you.
No, of course, you were great.
That's
And
fine.
I would like to say thank you,
Presentation was
Ahmed,
excellent.
for organizing this as well.
Thank you.
Wonderful webinar.
Thank
Good
you so
night.
much. And really appreciate for your time on a weekend. Really appreciate that.
Thank you, guys.
Thank you.
Right.
Bye-bye.
Bye bye.
Bye-bye.
Bye.
Good
Thank you.
night.
Bye-bye.